Yep, I sure can. Yep. Sure, sounds good. Thanks. Yeah, it's much better actually. April and May were very bad, but I think by the vaccination campaign finally caught up and things really settled down. So yeah, a lot of restrictions have been lifted and moving back towards normal. It looks like we might be at the outset of another wave though. The curve is starting to slowly rise again. So we'll see where this lands, but it may be quite different this time around because most people are vaccinated. So hopefully we won't get nearly as many hospitalizations, even if the case counts are rising. Not so much. Delta variant, I think this is why it's starting to go up now, is because the Delta variant is just sort of arriving, starting to take hold. But yeah, unfortunately, we don't.
Crítica en su 24ª edición. Les agradecemos muchísimo el conectarse nuevamente con nosotros. Mi nombre es Pedro Alvarado, soy un internista y un intensivista egresado del Instituto Nacional de Nutrición Salvador Subirán, aquí en la Ciudad de México. Yo los voy a estar acompañando durante las presentaciones o a lo largo de las presentaciones que tenemos preparadas el día de hoy para todos ustedes. Estoy seguro que el día de hoy cerramos con broche de oro. Vamos a tener la participación de 8 ponentes de renombre internacional que nos van a hablar de distintos temas de gran importancia para la medicina crítica de la actualidad. Entonces, pues sin más, procedo a presentarles exactamente de quién estamos hablando. Vamos a tener la participación del doctor Ewan Goligher. Él tiene programadas 2 sesiones. Nos va a hablar de disfunción diafragmática en ventilación mecánica y también nos va a hablar sobre el tema de volumen corriente contra presión de conducción o driving pressure en síndrome de insuficiencia respiratoria aguda. El doctor Goligher es profesor asistente en la División Interdepartamental de Medicina Crítica de la Universidad de Toronto y es científico clínico en University Health Network. También vamos a contar con la honorable participación del doctor Jean-Louis Teboul. Él nos va a hablar de 2 temas también. Él nos va a hablar sobre el manejo hemodinámico en pacientes con COVID-19 y también nos va a dar una actualización sobre la evaluación de respuesta a líquidos. El profesor Teboul es profesor de terapéutica y medicina de cuidados críticos en la Universidad París-Sur en Francia y ejerce su actividad clínica en la Unidad de Cuidados Intensivos Médica del Hospital Universitario de Vincent. Posteriormente vamos a contar también con la participación del doctor Phillip Dellinger. Él va a tener una intervención en cuanto a presión de conducción o driving pressure y reclutamiento alveolar. Él es profesor de medicina y distinguido académico en la Cooper Medical School de la Universidad de Rowan. Es asistente de cuidados críticos senior y director del Cooper Research Institute en Cooper University Healthcare. Y además es profesor adjunto en el Departamento de Medicina Pulmonar de la University of Texas MD Anderson Cancer Center. También vamos a continuar posteriormente con la participación del doctor Luciano Gattinoni, quien nos va a hablar sobre ventilación mecánica invasiva en el paciente con COVID-19. Él actualmente es profesor de anestesia y cuidados intensivos de la Universidad de Göttingen, Alemania. Y bueno, pues es quien introdujo el concepto del baby lung o pulmón de bebé, que ha servido como un marco conceptual para el desarrollo de la investigación sobre la fisiopatología del SIRA como tal. Asimismo, vamos a contar con la participación posteriormente de la doctora Janice Zimmerman. Ella nos va a hablar sobre trombocytopenia trombótica, HIT y más. La doctora Zimmerman es intensivista en Houston, Texas. Ella actualmente tiene licencia para ejercer en medicina en Texas, Wyoming y Minnesota. Es profesora adjunta en el Colegio de Medicina de Baylor y presidenta de la Federación Mundial de Cuidados Intensivos y Críticos. Posteriormente vamos a tener la participación también del profesor Jean-Louis Vincent. Él también va a tener 2 intervenciones, una de ellas titulada ¿Necesitamos SIRA? Y la siguiente será acerca de la SVO2, la relación entre aporte y consumo de oxígeno. Actualmente es profesor de Medicina de Cuidados Intensivos en la Universidad Libre de Bruselas, intensivista en el Departamento de Cuidados Intensivos de la Universidad Erasmus Hospital de Bruselas, Bélgica. Además de que es miembro de la Real Academia de Medicina de Bélgica, fue nombrado varón por el rey de Bélgica. Posteriormente vamos a contar también con la participación de Eddy Fan. Él nos va a hablar sobre ECMO para pacientes con COVID grave. Él es profesor asociado en la División Interdepartamental de Medicina de Cuidados Críticos y en el Instituto de Políticas, Gestión y Evaluación de la Salud de la Universidad de Toronto. Es intensivista en la red de salud de la Universidad del Hospital Mount Sinai. Y finalmente vamos a contar también con la participación del doctor John Marini. El tema del cual él nos va a hablar es: ¿necesitamos cambiar nuestro abordaje para ventilar pacientes con SIRA? Él es profesor de medicina en la Universidad de Minnesota, recibió su título médico en la Universidad de Johns Hopkins y ha servido anteriormente como profesor en la Universidad de Washington y en la Universidad de Vanderbilt. Él es miembro del consejo editorial de múltiples revistas científicas y educativas de alto rango. Estas van a ser las participaciones que vamos a tener. Vamos a empezar con la del doctor Ewan Goligher. en cuanto a disfunción diafragmática. Entonces, sin más, pues por favor, doctor, bienvenido.
Good morning.
Y es un verdadero placer que me hayan
This morning, my first talk is on diaphragm dysfunction in mechanically ventilated patients. And I want to briefly cover how we assess diaphragm dysfunction and why it matters in terms of the patient's outcomes. These are my disclosures. So the diaphragm is the primary muscle of inspiration. It's a large dome-shaped muscle that acts as the barrier between the thorax and the abdomen. And it's arranged such that it inserts at the bottom of the rib cage, and then there's a zone of apposition that runs abutting the rib cage, and then the muscle peels off the rib cage to form a dome. It's composed of a couple of different regions. There's the costal diaphragm, which inserts into the rib cage, of course, and the crural diaphragm, which inserts onto the vertebral column. And then there's a ligamentous region at the center of the diaphragm called the central tendon, which is where the various vessels transit through the muscle. In terms of understanding the action or motion of the muscle, I think it's important to appreciate that it primarily functions much like a piston within a cylinder. So when the diaphragm contracts, there's relatively little shape change in the muscle, but the dome descends and the zone of apposition shortens so that it's acting like a piston in a cylinder. Now, there is an interesting oppositional force of the diaphragm. So as the dome descends, the abdominal pressure underneath the diaphragm increases, and that actually pushes the rib cage outward. That's the so-called appositional force of the diaphragm. This figure nicely illustrates the functional mechanics of the muscle. So when the crura of the diaphragm contract, that pulls the dome of the diaphragm down, but at the same time, contraction of the costal region elevates the bottom of the rib cage. And then there's also the appositional force, which pushes the rib cage outward. So the muscle effectively, when it contracts, lowers the dome, raises the rib cage, and forces the rib cage outward. So it's a very efficient mechanism for generating an increase in thoracic volume and for ventilation. Now, how do we assess the function of the muscle? Well, like any muscle, you assess its function in terms of its force generating capacity. And in order to assess force generating capacity, you need a standardized stimulus to the muscle. Now, conventionally, that's done in healthy subjects by a maximal inspiratory pressure, also called a negative inspiratory force, where the subject makes a maximal effort against an occluded airway, and you use that pressure measurement to assess the force generating capacity of the muscle. In critically ill patients, this is challenging, of course, because many patients are unable to participate or to follow instructions, and therefore the reliability of volitional maneuvers is can't really be counted on. So one of the most important techniques that's been developed is the use of magnetic twitch stimulation of the phrenic nerve, which generates a standardized stimulus to the phrenic nerve, and the airway pressure during an airway occlusion developed during a magnetic twitch stimulus provides a useful measure of and a valid measure of diaphragm function. But this is an extremely tricky technique. Having used it myself, I can tell you honestly, it can be challenging to position the magnets correctly. There's a lot of different factors that can interfere with the stimulus. So it remains largely a research technique. And some of the most important studies in the field have been published using this technique, but it would be hard for this technique to make its way into routine clinical practice. One of the important methodological and technical advances in the field was the widespread introduction of diaphragm ultrasound. So this technique can be performed in a couple of different ways. I'm going to show you the measurement of diaphragm thickness here, which is performed by placing a linear array probe on the side of the hemithorax. And you can visualize the diaphragm in cross section. Here's the pleural line and the peritoneal line, and this zone in between those two lines represents the muscle. And you can see that it's the diaphragm muscle because whenever the muscle contracts, you can see it thickening up very nicely. This is an image from a healthy subject here. So you can see as the muscle contracts, it shortens and hence it thickens in the zone of apposition. And this technique allows you to image that thickening. And if you place the ultrasound in M mode, you get an image similar to what is shown here on the right, where you have at time points A and C, you have expiratory relaxation, and then at time points B and D, you have the peak inspiratory thickness of the muscle. And this turns out to be a useful non-invasive surrogate for contractile activity of the muscle and the contractile force generated by the muscle. And so this allows us to make measurements in mechanically ventilated patients. And because it's non-invasive, it doesn't require esophageal instrumentation or magnets, it's really made a large-scale study of the diaphragm much more feasible in the clinical setting. Now, just in terms of understanding the physiology of diaphragm thickening, it's important to appreciate that, as I said, when the diaphragm contracts, its shape or conformation changes relatively little in this axis. So you can see that in cross section, the actual shape of the dome isn't changing very much in this MRI study. What is changing markedly is the length of the zone of apposition. So here at rest, this black point here represents the point where the muscle starts to abut the chest wall. And you can see that during inspiration, the length of the muscle is markedly reduced so that now it's abutting the chest wall at this point. So what this means is that shortening and thickening of the muscle in the zone of apposition is a very good surrogate marker for the degree of muscle contraction. You can see that here in this figure, again, in healthy subjects, where as inspiratory volume as a percentage of inspiratory capacity increases, the thickening fraction of the muscle increases. This has been well validated as a useful measure of muscle function in mechanically ventilated patients. The paper here, figure here on the left, is from a study in ventilated patients that compared the thickening fraction measure to the twitch airway pressure using magnetic phrenic nerve stimulation, the gold standard technique. And you can see here a fairly nice correlation between the two, so that when the thickening fraction is high, that also implies a relatively high twitch airway pressure generation. When thickening fraction is low, particularly below 20%, that's consistent with a relatively low twitch airway pressure level. And you can see here that in terms of sensitivity and specificity for the diagnosis of diaphragm dysfunction in mechanically ventilated patients, the twitch airway pressure and the thickening fraction of the diaphragm perform relatively similarly. So this is a very useful technique. It's quite a reliable technique, and it's very easy to learn. It's much easier than many of the other ultrasound and echocardiographic techniques that are now routinely employed by intensivists. So I'd encourage you to read some papers about this and to try it out at the bedside. You'll find it's eminently feasible. So with that kind of physiology and functional assessment background in mind, let's think about the importance of diaphragm dysfunction in mechanically ventilated patients. Now, there's many reasons why ventilated patients develop diaphragmatic weakness: sepsis and systemic inflammation, the electrolyte imbalances associated with critical illness, potassium and phosphate derangements in shock states with decreased muscle perfusion, some of the medications we administer, of course, including steroids, certain antibiotics such as aminoglycosides, the residual effects of neuromuscular blockade, Of course, there's the extremely well recognized phenomenon of critical illness neuromyopathy, which can affect both the diaphragm and the phrenic nerve. And interestingly and importantly, over the last 20 years, we've come to appreciate that the ventilator itself is an important cause of diaphragm injury and dysfunction. And so when increasingly we recognize that when we're setting the ventilator, we need to consider how those settings might affect the diaphragm. And this leads us to the concept of diaphragm protective ventilation, which has now been widely discussed in the literature. So what is some evidence that the diaphragm matters in terms of patient outcomes? Well, this is a study that we published a year and a half ago, demonstrating an association between the thickness of the diaphragm at baseline after patients have been intubated and the clinical outcomes. So you can see here that in this cohort study of about 200 patients with a higher baseline diaphragm thickness had better survival over time compared to patients with a reduced diaphragm thickness at baseline. So these are patients who are coming into the ICU with diaphragm atrophy. And of course, this may be a reflection of chronic frailty or muscle weakness versus an intrinsic impact of the muscle atrophy on the outcome per se. But it indicates that the diaphragm atrophy and weakness is clearly associated with higher mortality rate. And this association persisted in multivariable analysis. Similarly, patients with a higher baseline diaphragm thickness are liberated from the ventilator at a higher rate over time. And so the risk of prolonged mechanical ventilation is higher for patients who enter the ICU with a reduced diaphragm thickness. Diaphragm weakness, diagnosed by twitch airway pressure measurement, is associated with important patient-centered outcomes, including difficult or prolonged weaning or death in hospital. This figure here shows the relationship between the risk of difficult weaning or prolonged weaning or death in the presence or absence of diaphragm weakness. So if you focus here, this bar here shows that patients with diaphragm weakness have nearly 50% chance of encountering difficult weaning and is markedly elevated in comparison to patients without diaphragm weakness. Similarly, patients with diaphragm weakness are at much higher risk of prolonged weaning and of death in hospital. Now, it's also striking to note here from this very nice paper by Martin Dress and colleagues, the group in Paris, is that the clinical outcome, the difference in clinical outcome between the presence and absence of diaphragm weakness is much more marked than it is for the presence or absence of limb muscle weakness. And so I want to emphasize that while peripheral muscle weakness gets a great deal of appropriate attention as an important form of ICU-acquired weakness, respiratory muscle weakness is, if anything, a stronger predictor of some of these important near-term patient outcomes. On the other hand, I would point out that limb muscle weakness seems to be more strongly associated with long-term functional outcomes. So both of these forms of muscle weakness, they develop at different times. They're not specifically associated with each other in the short term, and they have different associations in terms of long-term outcomes. So diaphragm weakness should not be thought of simply as another kind of peripheral ICU-acquired muscle weakness. These are two different clinical entities. Respiratory muscle weakness is also associated with a higher risk of long-term mortality over the year after ICU discharge. And so this highlights that the sequelae of the development of diaphragm dysfunction may be an important determinant of the patient's long-term functional status. And so targeting and improving diaphragm function may be associated with an accelerated recovery from critical illness and a better long-term patient outcome. And not only has measurements of respiratory muscle strength and diaphragm strength in terms of twitch airway pressure and maximal inspiratory pressure been associated with outcome, but the ultrasound-based measurements have also been clearly associated with outcome. This is a nice analysis here by Clement Medrinol, who showed that across many studies, a reduction in diaphragm thickening fraction is associated with a higher risk of death, and similarly with a higher risk of weaning failure. So consistently across many studies, a reduced diaphragm thickening fraction is predictive of mortality and prolonged mechanical ventilation. So this again reinforces the clinical relevance of this simple clinical measurement at the bedside. Now, I want to, in the time that remains to me, just very briefly cover the specific entity of ventilator-induced diaphragm dysfunction. This was first recognized in the 1980s. It was described by Knisley and colleagues in autopsy study of neonates that were on the ventilator for only a very short period of time before they died, and relatively normal myofibrillar cross-sectional area of the diaphragm. And by contrast, you can see this fibrosis and marked myofibrillar cross-sectional area reduction in neonates that had been on the ventilator for a much more prolonged period of time. So this was really the preliminary observation that raised the possibility that mechanical ventilation might cause diaphragm atrophy. And subsequently in animal models, it has been repeatedly demonstrated that even a short period of passive mechanical ventilation for 24 hours is associated with a rapid onset of profound diaphragm atrophy and dysfunction. And so this early disuse phenomenon seems to be a very important mediator of diaphragm weakness in mechanically ventilated patients. And in fact, there's probably several different mechanisms, not only disuse of the muscle from over-assistance, but also load-induced injury from under-assistance, and possibly injurious forms of loading associated with certain types of patient ventilator dysynchrony. There may be multiple different mechanisms of diaphragm injury from mechanical ventilation, and this may account for the fact that diaphragm weakness is so prevalent in this population. This is the seminal paper that demonstrated the phenomenon of disuse atrophy for the first time in humans. You can see here that in comparison to controls, which were patients undergoing thoracic surgery for just 3 or 4 hours, cases which were brain dead organ donors who'd been brain dead for anywhere between 18 to 69 hours exhibited a marked myofibrillar atrophy of both slow and fast twitch fibers. And interestingly, this seemed to be diaphragm specific. There was no difference in cross-sectional area between cases and controls for the pectoralis major muscle. So this finding really was probably the first in-human demonstration that mechanical ventilation was associated with disuse diaphragm atrophy. There's also evidence to support the development of load-induced injury, as I mentioned. So just a short period of elevated resistive loading can result in marked muscle injury. So here, the control specimen, you can see the kind of beautiful and very well-organized muscle architecture. And just after resistive loading, you see inflammatory infiltration and breakdown of these muscle fibers, indicative of acute load-induced muscle injury. And when the muscle is inflamed as a consequence of sepsis, it is much more vulnerable to load-induced injury. So this may be really an important issue and reason why patients may develop diaphragm injury even before they're intubated, because if they're septic and systemically inflamed and then making vigorous inspiratory efforts to sustain ventilation in the context of respiratory failure, well, that may mediate load-induced injury even before they're intubated. And then if they're insufficiently supported after they're intubated and their respiratory effort levels remain high, that may mediate further load-induced injury. In this cohort study of diaphragm thickness over time that we published now several years ago, we demonstrated that the diaphragm atrophy during mechanical ventilation was exceedingly common. So we identified 3 different groups: patients who had relatively stable thickness over time. This was about 40% of the population, 45% of the population. Another group who developed a rapid early decrease in diaphragm thickness over time. And this again was about 45% of this cohort of patients, about 100 or so patients. So this demonstrated for the first time that this phenomenon of acute diaphragm atrophy during mechanical ventilation is extremely common in our patients. And interestingly, there was a small subset of patients who had a rapid early increase in diaphragm thickness. which may be indicative of inflammation from load-induced injury, although that remains more of a speculative hypothesis at this point. These changes that we observed in the diaphragm during mechanical ventilation were clearly associated with outcome. So patients who had no change in diaphragm thickness from baseline were had liberated at a relatively high rate in comparison to patients who had either a decrease or an increase in diaphragm thickness. You can see the risk of prolonged mechanical ventilation at day 21 is essentially doubled in the patients with early changes in the diaphragm within just 3 or 4 days of mechanical ventilation. So this is a very early phenomenon that is strongly associated with long-term consequences for these patients. And again, this association between an increase in diaphragm thickness during mechanical ventilation and poor outcome suggests that this is representative of or indicative of some kind of muscle injury that we don't fully understand. Similarly, there was a clear dose-response relationship between either decreases or increases in diaphragm thickness and the duration of ICU admission, which is a strong predictor of long-term functional outcome, and also of the risk of complications of respiratory failure, a composite of reintubation, tracheostomy, prolonged ventilation, or death. So preventing these changes in diaphragm thickness by optimizing patient respiratory effort might actually have an important benefit in terms of clinical outcome for patients. It might accelerate ICU liberation and prevent complications of respiratory failure. And interestingly, when we looked at the relationship between patient inspiratory effort measured by ultrasound, the diaphragm thickening fraction, which represents the contractile activity of the muscle, we looked at the relationship between that value over the first 3 days of ventilation and the duration of ventilation. There was this very interesting J-shaped relationship where patients with relatively low or absent respiratory effort or relatively elevated respiratory effort both exhibited a more prolonged duration of ventilation than patients with intermediate levels of respiratory effort. And of course, this is an observational finding. It's not, we can't draw firm causal inferences, but it suggests that possibly by targeting an intermediate level of respiratory effort, consistent with that seen in healthy subjects breathing at rest. You know, if I was to measure diaphragm thickening fraction in most of you breathing at rest, it would probably be in the 15 to 30% range. And so if we targeted that level of effort under mechanical ventilation, perhaps we could avoid the injury resulting from atrophy or from excess loading. And this leads really to the concept of diaphragm protective ventilation, which I would say was first articulated by Tobin and colleagues in a seminal review in Annals of Internal Medicine back in 2010. They wrote that to navigate a patient's safe passage between the scilla of excessive patient effort and the Charybdis of excessive respiratory muscle rest, we suggested clinicians carefully titrate ventilator settings and pay close attention to the contour of the airway pressure waveform. So really, when we're at the bedside, we want to paying close attention to the patient's level of respiratory effort, something that I'll speak to a little bit more in my second presentation. And I think by doing so, we may be able to avoid diaphragm disuse atrophy and also load-induced injury, and thereby improve outcomes for patients. So thank you very much. Be happy to take questions.
Thank you, doctor, so much. We will do the countdown. 3. Thank you, doctor, for your presentation. I honestly believe that this has been really wide-opening, because it's like taking a look at the other side of the coin to know how to ventilate our patients, and not only to protect the lung, but also the diaphragm. We would like to ask some questions coming from our team and from our participants, from our attendees. The first question is, we understand that diaphragm dysfunction has some well-shown prognostic elements, but in which patients do you recommend, would you recommend for us to look for the diagnosis of diaphragm dysfunction? I mean, in any patient that is being mechanically ventilated for more than 48 hours, or in patients who had a difficult ventilator weaning? And also, will the diagnosis help you make a specific clinical decision? Those who have prolonged ventilation will undergo tracheostomy, for instance.
Sure. Thank you. That's a great question. I think that the available evidence would suggest that it's useful to measure diaphragm function in patients who develop or encounter difficulties being weaned from mechanical ventilation. I agree that perhaps the measurement doesn't need to be made in all patients, and certainly in my clinical practice, I don't do that myself. But if I have a patient who's encountering difficulty being liberated from mechanical ventilation, and particularly if they repeatedly fail the spontaneous breathing trial, I think it's very important to try to understand why that's the case. And so assessing the diaphragm function in a patient like that helps us to understand why the patient's failing liberation from mechanical ventilation. And that in turn provides, useful diagnostic, prognostic information. If a patient has severe diaphragm dysfunction, then it's clear that we need to be patient. It's going to take some time for the patient to recover and be able to be liberated. And so it sort of helps to set expectations for the clinical team, for the patient and the family. In my practice, I didn't have an opportunity to review this literature, but in some patients with persistent weaning difficulties who have diaphragm dysfunction, I'll initiate specific inspiratory muscle training, which is a relatively easy technique to activate the diaphragm, to try and strengthen it. It's been proven to effectively improve respiratory muscle strength. So we have a paper in the literature describing that technique and describing the evidence for it. And so sometimes in patients with diaphragm dysfunction on ultrasound, I'll arrange for inspiratory muscle training. But the diaphragm is activated in the context of all mobilization and all postural activities. So just having the patient dangling at the bedside, up in the chair, standing, walking to strengthen the core, I think will help to rehabilitate the diaphragm as well.
Thank you, doctor, so much. I fully agree with you. And we would also like to ask whether there are any pharmacological interventions, amtriptyline, for instance, or other drugs that have been used to improve the diaphragm function once we have a diagnosis.
There are no pharmacological agents that I'm aware of that have a meaningful clinical benefit. Certainly there are drugs, as you mentioned. Also levosimendan is another drug that's been studied quite a lot to strengthen or increase diaphragm contractility. But none of these agents really seem to have a clinically important benefit, at least given the present literature. And of course, they carry side effects or risk of side effects in these patients that we may generally want to avoid. So I don't think there is evidence to support routine use of pharmacological agents to treat diaphragm weakness.
When we measure the diaphragm thickening fraction, we know that there are several elements that may modify thickening. So for us to be able to correlate this with the gold standard, which is the pressure generated through electromagnetic stimulation, which are the support levels that we should give to the patient when doing the measurement so that we can make an appropriate diagnosis based on that specific measurement?
Yeah, thank you. That's a very thoughtful question. So I would say that the answer to the question depends to some extent on why you're doing the measurement. If you're doing the measurement to assess the patient's diaphragm contractility during tidal breathing, then you don't need to make any adjustments to the ventilator at all, because the thickening of the muscle represents its contractile activity. And so if you just put the probe on and under the current ventilator settings, you see that thickening is absent, or that there's a lot of thickening or just a little thickening, that tells you about the activity of the muscle under those conditions. On the other hand, if you want to assess the maximal performance of the muscle to assess its function or its strength, then you want to create conditions for the measurement that lead to a maximal diaphragm activation by the patient. So just as when you measure MIP, you try and coach the patient to do a maximal inspiratory effort, you're going to have to try and do the same thing when you're measuring maximal diaphragm thickening fraction. So the way that I do this is to temporarily put the patient in CPAP, or continuous positive airway pressure, to try and take away the the respiratory support in order to increase their respiratory drive and effort, or I'll put them in sort of the minimum level tolerated pressure support to sort of try and maximize their respiratory effort level. If that doesn't lead to vigorous inspiratory efforts, which you can kind of assess just by looking at the patient, looking for accessory muscle use, etc., then what I'll do is I'll apply a temporary airway occlusion. This is the so-called Marini maneuver. And so that temporarily occludes the airway, forces the patient to make larger efforts. And then once the airway occlusion is released and the patient is still making vigorous inspiratory efforts, but inhaling and exhaling, that's the time when I will do the thickening fraction measurement. And that's basically a way of getting the muscle to be maximally stimulated in order to assess its function. So that's how I go about using the ultrasound to assess maximal thickening fraction.
Thank you so much, Doctor. Let me check if there are any other questions. Is there any relationship between nutritional support the patient has received and diaphragm dysfunction development? I mean, nutritional status has anything to do with developing this pathology?
Interesting question. Not that I know of, to be honest with you. The studies that I've seen have not found an association between nutrition in the ICU and the diaphragm, but I wouldn't say there's any definitive studies on the topic. Certainly, patients who come in at baseline with relatively atrophic diaphragm are at higher risk of poor outcome, like I showed at the beginning. And many of those patients, some of that will have global muscle atrophy, not just diaphragm atrophy. And some of that may be nutritional nature, may also be reflective of chronic lung disease and so on, and the kind of metabolic effects of chronic respiratory disease. So I think nutrition is an important consideration, but it certainly doesn't explain the development of diaphragm atrophy or weakness during the early course of the ICU admission. That has much more to do with the level of activity of the muscle.
Thank you, Doctor, so much for all your answers. And now we will move on. We will go back to you after our next talk, but we will now close this part and we will give the floor to Dr. Jean-Louis Teboul. Thank you.
Hello everyone, I am Jean Teboul from Paris. I'm very honored to participate in this conference. I thank a lot the organizers, but it's a pity I cannot meet you face to face, maybe another year. So my topic right now is to speak about hemodynamic management of COVID-19. My conflicts of interest are on this slide. So I want to answer this first question. Is hemodynamics an issue in COVID-19 critical ill patients? And this is a question asked in this survey published recently. It was a worldwide survey, and 1,000 intensivists responded this survey. And what is interesting is that when the question about measurement of monitoring of cardiac output was asked, 69% of the respondents said yes, we measure cardiac output or we monitor cardiac output. In the majority of cases, echo was used, sometimes transpulmonary hemodilution, sometimes uncalibrated pulse control monitors or Swan catheter. So this is an issue, in fact, for COVID-19 patients if we trust this survey. So if you have no hemodynamic instability, of course, there is no need of any hemodynamic therapy. But sometimes, and relatively frequently, we have hemodynamic instability. And this could be due to different mechanisms, which can be either isolated or combined. Vasoplegia, hypovolemia, right ventricular failure, or myocardial injury. What about right ventricular failure? This study, published last year in Circulation, analyzed 100 consecutive patients with COVID-19, and the authors performed systematically echocardiography within 24 hours of admission. And they found that RV dysfunction or RV dilatation was present in 39% of cases, so it is not negligible. What could be the major etiologies, reasons for RV failure of dysfunction? Of course, it could be due to ARDS-related pulmonary hypertension, could be due to mechanical ventilation-related pulmonary hypertension, for example, due to high transpulmonary pressure or hypercapnia in some cases, or could be due to massive pulmonary embolism. And this is not an exceptional cause of RV dysfunction in COVID-19 patients. This is a meta-analysis looking at the presence of pulmonary embolism in COVID-19 patients, and many studies were pooled in this meta-analysis, and you can see that overall, around 90% of cases, pulmonary embolism was diagnosed. So it's not negligible. And one of these studies looked at the presence of pulmonary embolism, and they found that 21% patients in a series of 107 patients had pulmonary embolism. These patients were only COVID-19 ICU with pneumonia. But interestingly, the authors compared to a series of patients hospitalized 1 year before in 2019, and they found that the percentage was only 6%. So COVID-19 is associated with pulmonary embolism more than other disease found in ICU patients. Of course, if you want to diagnose or detect RV dysfunction, you should rely on some markers, high CVP, troponin levels, and echocardiography, of course, which is the best one. What about myocardial injury? Many mechanisms can be responsible for myocardial injury in COVID-19 patients. Could be due to viral myocarditis, the direct effect of the virus on the myocardium. Could be due to the cytokine storm, which is present in COVID-19 patients. Could be due to some microvascular or thrombotic injury into the myocardium, of course, and many other reasons. The main clinical manifestations are arrhythmias, but also heart failure or sometimes cardiogenic shock. And of course, you can detect or suspect myocardial injury by ECG, by cardiac biomarkers like BNP or troponin, or again, echocardiography. And in this study, I already talked about in 100 consecutive patients with COVID-19, LV systolic dysfunction was found in 10% of them. It is not negligible. And LV diastolic dysfunction was found in 16% of them. Hypovolemia is a very important issue in COVID-19 patients, especially in patients with ARDS. If we rely on the surviving sepsis campaign guidelines dedicated to COVID-19, the experts said that for acute resuscitations of adults with COVID-19 and shock, they suggested using a conservative over liberal fluid strategy. It was a weak recommendation. Nevertheless, I don't fully agree with this recommendation. I want to tell you why. I want to go back to pathophysiology of COVID-19 to answer this question. In many patients, as you know, in the ICU, ARDS is present. It is due to endothelial cell damage, and this results in VQ mismatch and lung capillary leakage. And lung capillary leakage, of course, also results in VQ mismatch and finally results in severe hypoxemia. At the same time, we frequently have coagulopathy in these patients with a high risk of thrombosis, and sometimes thrombosis occurs in pulmonary vessels. And therefore, it also could be could result in VQ mismatch and hypoxemia. But hypovolemia also can be present due to dehydration related to high fever, sometimes fluid losses, or decreased water intake in the previous days. But also, hypovolemia could be related to sepsis in relation to cytokine storm, and this results in capillary leakage and absolute hypovolemia or increased venous capacitance with relative hypovolemia. And therefore, this could result in low blood flow and eventually to multiple organ failure. But low blood flow also can result or can increase the risk of thrombosis, which in turn results in multiple organ failure. Low blood flow also can worsen hypoxemia due to the low PVO2 effect in case of high pulmonary shunt, and high pulmonary shunt is very frequent in ARDS patients, so this effect cannot be neglected. So if you give fluid now, you can prevent all these, you can aggravate lung capillary leakage and of course hypoxemia, but you also can prevent all the deleterious effects of hypovolemia on low blood flow, multiple organ failure, risk of thrombosis, and the low PV2 effect. So there is a balance between deleterious effects on lung capillary leakage and beneficial effects of preventing the consequences of hypovolemia on hemodynamics. So there is a benefit-risk balance of fluid infusion, and we need to assess this at the bedside by assessing the benefits, the numerator, by the degree of fluid responsiveness and the risk by some markers of worsening of lung edema. I start by the benefit, the degree of fluid responsiveness, and now we have many international societies which recommend to use dynamic over static variables to predict fluid responsiveness. And what is the dynamic parameter of fluid responsiveness? We have two categories. We have heart-lung interaction indices and passive regression test. Of course, heart-lung interaction indices are doable only in patients who receive mechanical ventilation, and the most popular indices are those related to the respiratory variation of stroke volume, namely pulse pressure variation or stroke volume variation. And for pulse pressure variation, which is one of the most popular indices, we know that when we have a high PPV, high pulse pressure variation during mechanical ventilation, this is generally associated with preload responsiveness. And in this case, if you give fluid to patients, they would increase cardiac output. But conversely, if you have a low PPV, low pulse pressure variation, it is generally associated with preload unresponsiveness. And if by mistake you give fluid to these patients, there is no benefit of fluid infusion, and there is a high risk of pulmonary edema in these patients. Years ago now, with Frédéric Michard and others of my institution, we first showed that pulse pressure variation was far better than central venous pressure, CVP, and POP to predict fluid responsiveness in septic shock patients. And this study was confirmed by many others. But pulse pressure variation is not applicable in patients with arrhythmias, with low tidal volume ventilation, with spontaneous breathing activity, and in other situations. So we need other tests in these situations. And for example, we can use a tidal volume challenge, which is a very convenient test. And this is, you can use this tidal volume challenge in case of low tidal volume ventilation. For example, 6 ml per kilogram of tidal volume. And some years ago now, with Sheila Mayatra from Mumbai, India, and others, we proposed to use the tidal volume challenge by increasing tidal volume transiently for 1 minute only from 6 to 8 ml per kilogram. And we looked at the prediction of fluid responsiveness and ROC curves. At 6 ml per kilogram tidal volume, the prediction of fluid responsiveness using pulse pressure variation was not satisfactory enough. It was far better for 8 ml per kilogram, but what was far better was a change, the absolute change of pulse pressure variation from 6 to 8 ml per kilogram. And we found a cutoff value of 3.5%. For example, if you have a PPV of 7%, was a patient, while the patient is ventilated with a tidal volume of 6 ml per kilogram, and you increase tidal volume to 8 ml, and now PPV goes up to 11%, you can assume that the patient would respond to fluid administration. If PPV goes up from 7% to 9%, you can assume that the patient would not respond to fluid administration. This is a very simple, very convenient test to perform because it is, you can use it even in the absence of cardiac output monitoring. And this is very helpful in COVID-19 patients. Another test also is doable in this situation. This is the end expiratory occlusion test. In fact, briefly, this consists in interrupting the ventilator for 15 seconds at the end of expiration. And this can create a transient increase in venous return and preload, and this can behave as a preload challenge. And you can identify fluid responders by patients who increase their cardiac output during this end exploration occlusion test. And this is what we found, and we showed in this meta-analysis with Francesco Gavelli, Xavier Monet, and others. We pulled 13 studies that all address the issue of prediction of fluid responsiveness using the end-expiratory occlusion test. And the area under the RO curve, the summary area under the RO curve, was excellent. 0.91 is a good sensitivity and good specificity. And we found a cutoff value of 5%. In other words, patients who increase cardiac output by more than 5% during this very short test are full responders. And this test is very useful in patients with ARDS, with low lung compliance. In this study we performed some years ago with Xavier Monet and others in my unit, we showed that the effects of end-expiratory occlusion test on cardiac output well predicted full responsiveness with an excellent area under the RO curve compared to pulse pressure variation alone. Passive grazing test is another possibility. You can use it in any situation with or without mechanical ventilation. You know this postural maneuver, which is able to transfer blood from the legs and the abdominal compartments towards the intrathoracic compartment, and this mimics free challenge. And in this meta-analysis with Xavier Monet and Paul Merrick some years ago, we included 21 clinical studies that address the issue of fluid responsiveness using passive leg raising, PLR, and almost 1,000 patients were included in this meta-analysis. And we showed that the changes in cardiac output during PLR were excellent to predict fluid responsiveness. Look at the area under the RO curve for all these studies pulled together. And we found a threshold value of 10%. And again, it is very useful in patients with low respiratory system compliance, less than 30 ml percentage of water, far better than pulse pressure variation alone. So it is possible to assess the benefit, the degree of fluid responsiveness. And interestingly, in the survey I talked about at the beginning of my presentation, fluid responsiveness is assessed by 84% of the respondents, either by echo, PPV, PLR, or any other devices. So it is a very frequent issue in the respondents. But we also have to assess the risk of worsening of lung edema, because we have to deal with a disease which includes ARDS and lung capillary leakage, so it is sometimes very risky to give fluid to patients. And in this paper, expert panel paper published some years ago with the cardiovascular section of the ESICM, the European Society of Intensive Medicine, we propose that in case of shock and associated severe ARDS, and this is the case many times in COVID-19 ICU patients, it is better to directly propose an advanced hemodynamic monitoring technology like transpulmonary thermodilution system or PA catheter, especially in case of RV dysfunction. Transpulmonary thermodilution system can provide the value of extravascular lung water, EVLW, which is a quantitative measure of lung edema. It is very, very helpful in this situation of COVID-19 ARDS patients. In this very recent study with Ruishi and Xavier Monet and others, we measure extravascular lung water in COVID-19 ARDS patients, and we subdivided patients in 3 categories: severe ARDS, moderate ARDS, and mild ARDS. And we took the value of lung water for the lowest PF ratio during the stay of the patient. And we subdivided in 5 ranges of lung water. The green one is the normal lung water value, and the black one, the worst. As you can observe, in patients with severe ARDS and moderate ARDS, many times we have a very high value of lung water. And of course, in these patients, fluid infusion is very risky, even in cases of shock and the presence of pleural responsiveness. But sometimes, for example, for this patient with severe or moderate ARDS, we have some relatively low values of lung water. And of course, in these situations, fluid infusion can be attempted in case of shock and pleural responsiveness because the risk is not as so marked. Therefore, the value of lung water can help you to manage patients, in particular to decide to give fluid. Now, if the decision of fluid infusion is made, which type of fluid should we administer? And the recommendation of the surviving sepsis campaign is to use crystalloids over colloids, to use balanced over unbalanced crystalloids. It is recommended against using starches, gelatins, dextrans, and albumin for the initial resuscitation. Now, vasoplegia. Vasoplegia also can be present in COVID-19 ICU patients, at least due to the use of high-dose sedative drugs, which are also vasodilating drugs. And sometimes because of presence of septic shock associated with ARDS. And it is very easy to detect vasoplegia at the bedside just by looking at the low diastolic arterial pressure. When diastolic arterial pressure is low, in general, it is due to low arterial tone. And therefore, in this situation, you should consider vasopressors. And sometimes even before giving fluids, just to counteract the effects of sedative drugs. And this survey showed that the use of vasopressors in COVID-19 ICU patient is very frequent by intensivists. If you use vasopressors, it is suggested to use norepinephrine first, and if it is not enough, to add vasopressin as a second-line agent if target AMAP cannot be achieved by norepinephrine alone. Also, it is recommended or suggested in case of refractory shock to use steroids for its shock reversal activity. So my conclusion, it is very important to use a personalized assessment and decision in terms of hemodynamics. The decision of fluid infusion should be considered in cases of hemodynamic instability with organ failures, of course. The benefits should be assessed by fluid responsiveness test. They should be higher than the risk, which can be assessed by lung tolerance indices. It is also important to give norepinephrine in case of low diastolic arterial pressure, even at the early phase. The MAP target should be individualized and should be increased if prior hypertension, of course, and vasopressin is used as a second-line agent. But don't forget to exclude massive pulmonary embolism or myocarditis as potential causes of shock, and there is a major place of echocardiography to detect pulmonary embolism or myocarditis. Now I would like to thank you for your attention. Thank you very much.
And we want to thank you greatly for your presentation. We believe that it was excellent. And we have just a short time for questions, but there is one that is very interesting here, submitted by our audience, that I'm going to try to explain. In those patients that have COVID-19 with severe ARD in prone position, it is frequent that we would find the patients that have right ventricular dysfunction who we have already ruled out that it could be pulmonary embolism, and that we have the diagnosis that this is an increase in vascular resistance of the lung, which is causing the right ventricular dysfunction. In prone position, this would make it difficult to perform, or it makes it impossible to do the passive leg raising. But right ventricular dysfunction has an interference. Also, importantly, it gives you false positives. Also, in terms of the indexes that depend of the cardiopulmonary interaction in terms to the response to liquid fluids. In that case, what we do to determine if the patient is a responder or is not a responder.
Thank you for your question. This is an excellent question. First, we have to know that RV dysfunction can be improved by prone positioning. Some years ago, we published a paper, and others published papers about the beneficial effects of prone position on RV function, in particular in patients with RV dysfunction. So you can improve a lot. You can improve a lot the pulmonary vascular resistance, the increased pulmonary vascular resistance in case of prone positioning first. But your question is about how to assess fluid responsiveness in this situation. So this is a good question because there are not so many papers, and we are right now finishing a study. We are preparing the manuscript, and we should submit the manuscript in the next weeks, where we try to use either the Trendelenburg maneuver, so the opposite of passive leg raising, or tidal volume challenge, or end expiratory occlusion test. And it seems that tidal volume challenge, which is very simple, because it does not need any cardiac output monitoring, just an arterial line, is very reliable, and we found very good results with tidal volume challenge to predict fluid responsiveness. So even if the patient is in prone positioning, you can increase tidal volume just for 1 minute from 6 to 8 ml per kilogram and look at the change in PPV. If PPV increases, you can think that the patient is fluid responsive. Now this paper is not published, is not yet published, not yet submitted. We should submit it in some days. So I have to be very careful, but it seems to work.
Okay, doctor, thank you very much. Unfortunately, we do not have time for further questions, and we're going to close the session, the question and answer session, and then we will return back to you in a moment. We will continue with the next presentation. Dr. Goligher, once again, thank you very much, doctor.
What I have to do, I have to close. Okay.
Yep. Thank you. Thank you again to the organizers for the invitation to present. I'm going to discuss now the question of driving pressure versus tidal volume, which has been an important area of controversy and uncertainty in the management of mechanical ventilation and ARDS over the last several years. These are my disclosures. So there's no disagreement that mechanical ventilation is life-saving, and perhaps the best evidence of that comes from the context in which modern mechanical ventilation really was first implemented, or routine positive pressure ventilation was really first implemented, the poliomyelitis epidemic in Copenhagen. And during that epidemic, you can see that during the early course of the epidemic at the Blegdems Hospital, nearly 90% of patients with respiratory involvement from paralytic polio died. And following the implementation of continuous positive pressure ventilation, those mortality numbers dropped dramatically down to about 40% on average in the ensuing months. So ventilation saved lives, but at the same time, we realized that it can do quite a lot of injury. And within 20 years of that original introduction of routine positive pressure ventilation and the development of the modern intensive care unit, it was recognized in a classic experiment by Webb and Tierney that the ventilator could actually cause ARDS. And this figure from their seminal paper published in the 1970s shows isolated lung model subjected to relatively low airway pressures, subjected to high airway pressures with some PEEP, and then high airway pressures with no PEEP at all. And you can see here already some lung edema in comparison to the reference model, and then here marked hemorrhagic necrosis. So it seems that mechanical ventilation can cause lung injury, and this led to the development of a variety of lung protective strategies, most importantly, the low tidal volume ventilation strategy. And the benefit of this in terms of mortality was demonstrated in the classic ARDSnet trial published now over 20 years ago. And since that time, low tidal volume ventilation has really become the standard of care for ARDS and for many mechanically ventilated patients more generally. Now, the interesting thing that as you look at this slide actually is that on the left, the lung injury from mechanical ventilation was generated by applying ventilation in terms of pressure. So the injury appeared to be achieved by applying a certain pressure. Whereas on the right, the ventilation strategy was applied in terms of tidal volume. And because of the success of that clinical strategy, clinical management and the risk of ventilator-induced lung injury was assessed primarily in terms of the tidal volume, not the airway pressure. And there was an important background to that development. This experiment here, published by Didier Dreyfus and colleagues in the 1980s, shifted the conversation from a focus on barotrauma to an appreciation of volutrauma, emphasis on the volume being applied to the lung. So they generated high inflation pressure pulmonary edema or ventilator-induced lung injury using three different conditions: a high airway pressure, high tidal volume model, a low airway pressure, high tidal volume model, and a high airway pressure, low tidal volume model. So this model here was generated by simply applying high airway pressures to achieve high tidal volumes. This model here was achieved by applying a negative pressure ventilation to achieve high tidal volume at low airway pressures. And then this model here was achieved by applying straps to the chest wall to increase chest wall elastance, such that with the application of high airway pressure, the tidal volume was still low. And what they demonstrated was that when the tidal volume was high, regardless of whether airway pressure was high or low, you observed evidence of significant lung injury with a marked increase in extravascular lung water, marked increase in lung weight, and in microvascular permeability. And by contrast, if airway pressure was high, but tidal volume was kept low, there was no evidence of significant lung injury developing. So this shifted the focus and attention away, and appropriately so, away from airway pressure to a focus on the tidal volume inflating the lung as the major mediator of and target for lung protective ventilation. But when you step back and think about it, a given tidal volume can mean two very different things in two different patients depending on the lung available for ventilation. And the real issue here that you're trying to minimize and avoid whenever you're trying to apply lung protective ventilation is to reduce lung strain. And that's really what volutrauma is about. It's the inflammatory response to excess global and regional lung stress and strain. But lung stress and strain is not just a function of what tidal volume you're applying, it's also how big of a lung you're applying that tidal volume into. And so a patient with a smaller end expiratory lung volume, the so-called baby lung, will experience much greater stress and strain from a given tidal volume than a patient with a larger end expiratory lung volume. And it's been convincingly shown in patients that the degree of lung strain developed during mechanical ventilation is directly correlated to the transpulmonary pressure developed during tidal ventilation. So not the tidal volume per se, but rather the transpulmonary pressure, or the pressure gradient between the inside of the lung and the outside of the lung during tidal ventilation. So really, even though we call it volutrauma, we're really concerned about lung stress and strain, and really that's a pressure issue rather than a volume issue per se, because patients vary widely in how much lung is available for ventilation. And so this conception led to what is called the driving pressure hypothesis. The hypothesis that the main way in which mechanical ventilation injures the lung is by applying excess driving pressure, or the increase in airway pressure during tidal ventilation. And that this was the real mediator of ventilator-induced lung injury, not the tidal volume per se. And this would have important implications for how we set the ventilator, of course, targeting driving pressure rather than tidal volume. And a number of important studies demonstrated that driving pressure is strongly associated with mortality. So this seminal paper by Marcelo Amato and colleagues in the New England Journal demonstrated that there was a clear association between driving pressure and the risk of death, even when tidal volume was relatively similar across groups of patients. You don't see a lot of difference in tidal volume on average between this group and this group, and still see some discrimination in mortality risk in terms of driving pressure. And similarly, my colleague here in Toronto, Martin Erner and colleagues with Eddy Fan reported a very strong association between dynamic driving pressure and mortality in a large cohort study of patients with hypoxemic respiratory failure. So there's convincing evidence that this marker driving pressure is associated with mortality. But the elephant in the room, the big challenge to interpreting this association is that because driving pressure also reflects the stiffness of the lung, and the stiffness of the lung is clearly reflective of the risk of death, the severity of the ARDS and the risk of death. This would suggest that this association between driving pressure and mortality might simply result from the fact that driving pressure also reflects more severe illness. So patients with higher driving pressure just have more severe ARDS and a worse prognosis. And so it's not so clear that this association is causal or merely a correlation reflecting severity of illness. So to try and test the driving pressure hypothesis, the theory that the real determinant of ventilator-induced lung injury is the driving pressure, and the tidal volume is more a cause of lower or higher driving pressure rather than the other way around. We have to get around this issue of confounding from elastance. And so the way that we tested the hypothesis was to look at the relationship between the effect of tidal volume on mortality in patients with higher elastance and lower elastance. And here's why. So if you take two patients, one of them with higher end expiratory lung volume, and you reduce tidal volume substantially, you'll get less benefit in terms of stress and strain than you would applying the same tidal volume reduction in a patient with a much smaller end expiratory lung volume. So here the reduction in stress and strain is going to be greater, and therefore the benefit in theory should be greater in comparison to a patient who accrues less reduction in stress and strain. Now the end expiratory lung volume is strongly or tightly associated with the elastance, and that's really because the mechanics of the lung and ARDS the degree of reduction in compliance or increase in elastance basically reflects the degree of collapse and consolidation and the size of the baby lung, essentially. So if you have low elastance, that means you've got a large volume of lung available for ventilation. Whereas if you have high elastance, then you have a relatively small volume of lung available for ventilation. So in theory, if the driving high pressure hypothesis is true, then you should see greater mortality benefit from lowering tidal volume in patients with high elastance versus lowering tidal volume in patients with low elastance. And so this is how we set out to test the driving pressure hypothesis. We were fortunate to get access to the data set that Amato and colleagues had used in their original analysis in the New England Journal. 5 randomized trials of lower versus higher tidal volume, of which the ARDS-NET trial is by far the largest. And we looked at the relationship between tidal volume, driving pressure, and elastance. These data are presented here. So the red line represents patients randomized to a lower tidal volume strategy, and the blue line represents patients randomized to a higher tidal volume strategy. And of course, you can see the tidal volume is on average much lower in the patients randomized to a lower tidal volume strategy versus a higher tidal volume strategy. But what I'd like you to note here is that if anything, the separation between the arms was, if anything, greater in patients with low elastance versus in the patients with higher elastance. Whereas if you look at driving pressure, the separation between arms in terms of driving pressure is much greater, as you'd expect, in patients with high elastance versus patients with low elastance. So what this sets up is an important way to test the hypothesis, because if lowering tidal volume is the main way that patients are benefited, then the benefit should, if anything, should be greatest in patients with low elastance. Whereas if lowering driving pressure is the main mechanism of benefit, then the benefit, if anything, should be greatest in patients with highest elastance. So this allows us to test this hypothesis. And what we found is a quite striking relationship between the difference in mortality between lower versus higher tidal volume and respiratory system elastance. So at relatively low elastance values, the risk of death was very similar in the lower and higher tidal volume arms. And the probability of absolute risk reduction was approximately 0 in patients with very low elastance. Whereas in patients with high respiratory system elastance, there was progressively greater separation between the arms, such that patients with high elastance had a very large difference in mortality between lower and higher tidal volume. And another way of looking at the same data is to look at the relationship between elastance and the probability of a treatment effect. So each of these curves here represents a different magnitude of treatment benefit. If you look at the red curve, that represents the probability of achieving a greater than 1% absolute risk reduction in mortality. You can see here that when elastance is low, the probability of achieving that benefit is really quite low. But once it exceeds 2 or 2.5, the posterior probability of mortality benefit from lowering tidal volume becomes substantially higher. And again, this is essentially correlated to driving pressure. And what's striking to me is that in the patients with low elastance, the driving pressure in the high tidal volume arm, that is patients being ventilated with 10 to 12 mils per kilo, was on average 15 centimeters of water. And in that group, there was really no association with lower benefit from lowering tidal volume. So this suggests that the driving pressure is useful as a marker of whether or not lowering tidal volume would be beneficial. And when the driving pressure is 15, there doesn't seem to be much evidence to suggest that lowering tidal volume would be particularly beneficial. So from a physiological standpoint, these data suggest that driving pressure rather than tidal volume probably really is the mediator of benefit from lung protective ventilation. And that if driving pressure is 15 centimeters of water or lower, then that probably represents safe mechanical ventilation, assuming that driving pressure is a causal mediator. So the question, of course, then is, well, what do we do with this Dreyfus paper, which shifted us away from airway pressure to tidal volume? Well, the real point of the Dreyfus paper was to demonstrate that it's not airway pressure that matters, but rather the transpulmonary pressure. And so even in this low airway pressure, high tidal volume model, the transpulmonary pressure was, if anything, similar or greater in the low pressure, high tidal volume group. And you can see that the risk of lung injury and development of lung injury is just as severe in this low airway pressure, high tidal volume group, because the transpulmonary pressure is just as enlarged. So this means that really when we're monitoring lung protective ventilation, where we need to be more focused on transpulmonary pressure even than airway pressure per se. Now, when patients are passively ventilated, the transpulmonary pressure swing is tightly correlated to the airway pressure swing. So we can be confident that transpulmonary pressure is appropriately limited if airway pressure is appropriately limited. But once patients start to develop spontaneous breathing, well, then transpulmonary pressure now can be substantially larger than airway pressure. And this is where the risk of lung injury from spontaneous breathing really becomes a concern. There are, of course, multiple experimental studies which quite convincingly demonstrate that spontaneous breathing can cause lung injury. This is the classic experiment from Ted Kolobau's lab, where they injected the sheep model with acetylsalicylic acid in the cisterna magna, generating a massive respiratory drive, which led to the development of lung injury as reflected by hypoxemia and a decrease in compliance. There's also the important data from Takeshi Yoshida and Brian Kavanaugh that convincingly demonstrated the injurious potential of injurious levels of spontaneous breathing. And as I said, because spontaneous breathing results in a decrease in pleural pressure, you can have much larger increase in transpulmonary pressure because pleural pressure is being reduced by the respiratory muscle effort. So for example, if you look at these airway pressure tracings here, the positive pressure swing in the airway pressure is only about 10 centimeters of water. But if you have an esophageal balloon in, you can see a negative swing of about 30 centimeters of water. So now the total transpulmonary pressure swing or total transpulmonary driving pressure is about 40 centimeters of water, showing that this lung is being substantially overdistended, even if the airway pressure itself looks reasonably protective. So this is why I want to convince you that we need to focus on the driving transpulmonary pressure rather than the driving airway pressure per se. Now, one of the big challenges to monitoring transpulmonary pressure has been the need for esophageal manometry, but really monitoring has become much easier and simpler in recent years, with a description of a couple of different techniques for assessing respiratory drive and effort in mechanically ventilated patients. So first of all, I monitor airway driving pressure routinely in all mechanically ventilated patients during controlled mechanical ventilation. It's a key target for ensuring that the lung is being adequately protected. During assisted ventilation, you can often successfully measure airway driving pressure by applying an end inspiratory hold. And what you see is that the airway pressure increases at the end of inspiration rather than decreases as you'd expect during passive ventilation. And this increase in plateau pressure represents the combined effects of the ventilator and the patient's respiratory muscles to apply a total airway driving pressure. Another technique that I use routinely is the measurement of POC, or expiratory occlusion pressure. So you simply apply an expiratory hold on the ventilator, and when the patient makes an inspiratory effort, you can see the magnitude of their inspiratory effort against the occluded airway. Giacomo Bolani sometimes refers to this as the iceberg. So normally on the ventilator, you can see the top of the iceberg above the water only, but with the application of the occlusion maneuver, now you can see the underside of the iceberg, and you can see just how much more pressure is being applied to the lungs. So we now have funding in Canada to initiate a clinical trial targeting these measurements of driving pressure and expiratory occlusion pressure to achieve lung protective ventilation in patients with hypoxemic respiratory failure. So I'll wrap up and with the following conclusions. I hope I've been able to convince you that the real target, given the data I presented, for lung protection is the pressure, not the volume per se. And that, in fact, the real target is not the airway pressure, but rather the transpulmonary pressure. And so I think the data that we have suggests that it's crucially important for us at the bedside to be monitoring respiratory mechanics and respiratory effort to minimize the risk of ventilation-induced lung injury. Thank you very much. I'd be happy to take questions.
Three, two, one. We understand that monitoring driving pressure over tidal volume is the conclusion of your talk, in the sense that it might be the mediator or one of the major VILI mediators in ARDS patients. But you also said that in some patients, due to the fact that we cannot exactly know what the transpulmonary pressure is, because there might be an increase of elastance of the chest. If we want to measure transpulmonary driving measure and not airways as such, how would we do that?
That's a very thoughtful question. So I think the scenario that you're describing that's of concern is a scenario where a patient has elevated chest wall elastance, or actually much more commonly, their chest wall pressure volume curve is shifted to the right, so that at a given volume, they have much higher airway pressures. And you are looking at the driving pressure, and it seems to be markedly increased for a given volume. How do you, can we tolerate higher plateau airway pressures in that setting? That's usually the main situation in which we're concerned about an increase in chest wall elastance in passively ventilated patients. And I think the good news is that as long as the airway driving pressure is 15 or less, you can be confident that the transpulmonary pressure is appropriately limited. Because if the chest wall elastance is increased, that means that the transpulmonary driving pressure is even smaller proportion of the airway driving pressure than it normally is. Normally in ARDS, the lung elastance accounts for about 80% of the airway driving pressure, and then the chest wall elastance accounts for about 20% of the airway driving pressure. But if you have an increased chest wall elastance, and now it's say 60-40, well, the actual transpulmonary driving pressure is going to be even lower than it would be if chest wall elastance was relatively lower. So I think with respect to driving pressure specifically, we can be quite confident that when chest wall elastance is elevated, the targeting driving pressure 15 will ensure adequate protection. Now, with respect to the issue of what plateau pressure to accept, because if you have an increase in chest wall elastance or a right shift in the pressure volume curve, then the plateau pressure would be higher, but not necessarily more injurious, because the transpulmonary plateau pressure is not increased. And you know, we just reported in a letter to the Blue in response to an editorial letter about our paper in the Blue, the date of which I showed you, the analysis showing that provided driving pressure is appropriately limited, the airway plateau pressure doesn't seem to be associated with an increased risk of death. So I think in all patients, the priority should be to ensure a driving pressure that's appropriately limited, also to limit plateau pressure as much as possible, but I think the data pretty convincingly suggests that the dynamic swing in pressure is much more important for lung protection than the static pressure alone.
Thank you so much, Doctor. We have another question from our audience, and they want to know whether the delta in the occlusion pressure could predict or could be correlated to an injurious transpulmonary pressure.
So that's an excellent question. Thank you. I didn't have time to go into detail on the previous work we've done to validate the expiratory occlusion maneuver, but in fact, that's exactly what that pressure swing tells you. So essentially, the pressure swing in the airway during the occlusion reflects the magnitude of the inspiratory effort. And because the mechanics of pressure generation are a bit different during an occlusion, what we've shown is that if you measure the expiratory occlusion pressure, let's say it's 30 centimeters of water, we've shown that if you multiply that by 2/3, that predicts what the esophageal pressure swing would be, which would be therefore about 20 centimeters of water. And when you add that to the airway pressure swing from the ventilator, let's say you're in pressure support of 10, so say 10 centimeters of water, now you have a total of 10 plus 20 centimeters of water of dynamic driving transpulmonary pressure. And we've published papers showing that that's actually quite a reliable and sensitive and specific way of detecting excess driving transpulmonary pressure during spontaneous breathing. So this is a very useful measurement to assess the risk of lung injury during assisted ventilation.
Thank you so much, Doctor. This was the last question. It has been a true honor to be able to listen to you, and we will close this part now, and we will give the floor to Dr. Jean-Louis Teboul for his next presentation. Thank you ever so much.
And again, I'm very, very honored to participate in your meeting, and I thank a lot of the organizers for this invitation. So right now, I will speak about assessment of responsiveness, why, when, and how. My conflicts of interest for this presentation are on this slide. First, I would like to define what is fluid responsiveness. It is defined as the capacity of the heart to significantly increase stroke volume or its cardiac output in response to a volume challenge. And I like to refer to the Frank-Starling mechanism with stroke volume on the y-axis and ventricular preload on the x-axis. You know that the mechanism, the curve is not linear, but curvilinear, meaning that if you increase preload for any of the two ventricles, you increase ventricular preload, for example, by giving fluid, and stroke volume increases only if the ventricle is operating on the steep part of the Frank-Starling curve. If you increase preload while the ventricle is operating on the flat part of the Frank-Starling curve, there is no increase in stroke volume. And this condition is called preload unresponsiveness, compared to this one, which is called preload responsiveness. And fluid infusion will increase the left ventricular stroke volume, and only if both cardiac output, if both ventricles are preload responsive. So there is some chance to increase cardiac output only if you have preload responsiveness of both ventricles. So preload responsiveness is equivalent to biventricular preload responsiveness. So why to assess preload responsiveness? There are different reasons, at least 5 reasons. First, because not all patients, even in shock, are preload responsive. And this is illustrated by this old study now that we performed with Frédéric Michard, and we pulled all the studies that at the time addressed the issue of preload responsiveness. And preload responsiveness was defined in these studies by any increase in cardiac output, sometimes more than 0%, sometimes more than 10%, 15 or 20%. Nevertheless, among 406 patients, only 52% of them increased their cardiac output in response to fluid administration, meaning that half of them did not. Another reason is that fluid responsiveness is a dynamic phenomenon. Dynamic phenomenon, it is well illustrated by this study. You know probably this Andromeda shock study performed in Latin America. And this study by Glenn Hernandez and co-workers compared to resuscitation strategies during septic shock at the initial phase, one strategy based on peripheral perfusion markers like capillary time, and a strategy based on the decrease in lactate levels. Interestingly, in this study, in 82% of cases, fluid responsiveness was assessed by the investigators. Only in 18% of them, there was no assessment of fluid responsiveness at the inclusion time. But interestingly, you can see that the degree of fluid response, the rate of fluid responders, which was 70% at H0, time of inclusion. Maybe you remember that patients receive fluids before inclusion time. So 70% were still fluid responders at H0, but after some time, H2, H4, H6, and H8, you have a decrease of the infusion rate, of the fluid responsiveness rate, and after 8 hours, only 4% were fluid responders. This illustrates the fact that fluid responsiveness is a dynamic phenomenon. Another reason to assess fluid responsiveness is because infusion in non-responders is risky, with a high risk of pulmonary edema, for example. And we know that also fluid overload in general is harmful. And this is illustrated by many studies. One of them is from Jean-Louis Vincent and co-workers, a sub-study in septic patients, showing that a positive cumulative fluid balance is an independent factor associated with mortality. And this study was replicated many times more recently. And the fifth reason is that the use of fluid responsiveness test is associated with improved outcome. And this is well illustrated by the study coming from Argentina, the group of Arnaldo Dubin and co-workers. It was a multi-center prospective cohort study in patients with sepsis. And interestingly, the use of dynamic tests of fluid responsiveness was associated with improved survival compared to independently of other factors. Just the use of dynamic test was associated with survival. So it is very important to test fluid responsiveness. Now, when should we test fluid responsiveness? If I take the condition of sepsis, for example, and given that hypovolemia is present in 100% of patients with septic shock, it is logical to infuse the fluid bolus early without any predictor of fluid responsiveness. In other words, be smart, but not too much, and don't waste too much time. Infuse fluids without thinking a lot about fluid responsiveness at the beginning of septic shock resuscitation. And what we propose is to infuse 10 ml per kilogram crystalloid within the first hour around this. This is the starting value, but of course, this starting value can be increased if there is a presence of fluid losses, of course, because hypovolemia should be more profound. In case of abdominal sepsis, also because in case of abdominal sepsis, hypovolemia is more profound. In case of mottling or increased capillary fluid time, which are associated with low cardiac output in general, and in this context, hypovolemia, and low pulse pressure, which is a rough marker of stroke volume, and low pulse pressure. If you have a low pulse pressure, you can think that the patient has a low stroke volume and therefore a low hypovolemia, because in this context, a low cardiac output is associated with hypovolemia in most cases. But also, you could decrease the infusion rate in case of worsening of tachypnea during infusion or fall in oxygen saturation. So what is important is to individualize your initial fluid therapy. After some time, maybe 1 hour, 45 minutes, it depends on the severity, and if shock persists, it is time to test pleural responsiveness. So the question now is, how should we assess fluid responsiveness? I like to refer to the Frank-Starling mechanism, but just before, I talk about one Frank-Starling curve, but there is not only one single Frank-Starling curve, but a family of curves between a normal heart and a failing heart. And therefore, if you assess preload, only preload, by any measure of preload, this value of preload can be associated with preload responsiveness in case of normal heart, or preload unresponsiveness in case of failing heart. So it's not possible from static measures of preload to predict fluid responsiveness. And this is illustrated by thousands of studies. One of them is a study we performed with David Osman and others in my institution and published 14 years ago now. Time is running. And we measured POP using a Swangan catheter and central venous pressure CVP in patients who will receive a fluid challenge. And we defined responders and non-responders by an increased cardiac output by more than 15% after fluid challenge. And we looked at the baseline value of POP and CVP just before giving fluids. And as you can observe, there was no difference between fluid responders and fluid non-responders in terms of baseline values of POP and CVP, and therefore, cardiac filling pressures are not appropriate to predict hemodynamic response to the challenge. And this study was replicated many times, and any measure of preload cannot reliably predict fluid responsiveness. And therefore, international societies like the European Society of Intensive Medicine, ESICM, but also the Surviving Sepsis Campaign dedicated to septic shock or COVID-19, recommend using dynamic over static variables to predict fluid responsiveness. But what is a dynamic variable? This is something which can quantify the slope of the Frank-Starling curve at the time you decide to give treatment to your patient. If the slope is elevated, you can think that the patient is fluid responsive. If the slope is low, you can think that the patient is not fluid responsive. How to quantify this slope? We can use some tests or indices, for example, heart-lung interaction indices or passive leg raising tests. Heart-lung interaction indices, they are doable only in patients who receive mechanical ventilation, of course, and the idea behind is that the more the cardiac output or the stroke volume changes during mechanical ventilation, the more likely the patient is preload responsive. And we have different categories of heart-lung interaction indices. We have the indices related to the respiratory variation of stroke volume, PPV, SVV. And again, high PPV in general is associated with preload responsiveness, and therefore the patient should respond to fluid administration if you decide to give fluid to the patient. And conversely, low PPV is associated with prolonged unresponsiveness, and if by mistake you give fluid to this patient, there is no benefits in terms of cardiac output increase, but there are some deleterious effects in terms of pulmonary edema development, etc. And this is the first study performed with PPV, and this study with Fimc and others, we showed that PPV was far better than CVP and POP to predict fluid responsiveness in terms of sensitivity and specificity. And this is a meta-analysis coming from China, published already 7 years ago, and they already included 22 studies that all address the issue of fluid responsiveness predicted by pulse pressure variation, and more than 800 patients were included. And note that in these studies, all these studies included patients with tidal volume of at least 8 ml per kilogram. As you can observe, the area under the rocker for all the studies, the combination is excellent, 0.94, and the threshold value is 12%. But there are many false positive, false negative cases in ICU patients due to arrhythmias, low tidal volume ventilation, spontaneous breathing activity, etc. So we need other tests. The tidal volume challenge is one of them. I already talked about the tidal volume challenge before, and this is a very simple test which can be used in case of low tidal volume ventilation. For example, if you ventilate a patient with a tidal volume of 6 ml per kilogram, and with Sheila Mayatra and other colleagues from India, we propose to increase tidal volume from 6 to 8 ml per kilogram over 1 minute only. And again, the value of pulse pressure variation to predict responsiveness at 6 ml per kilogram was not satisfactory enough in terms of ROC curve. It was better when we increased tidal volume and we read the value of PPV, but what was far better was a change in PPV when we moved from 6 to 8 ml per kilogram and found a cutover value of 3.5%. In other words, if you have a patient with a PPV of 7%, you increase tidal volume, and now if you read a value of 11%, you can assume that the patient will respond to fluid administration. And the opposite is true. If you PPV increases by from 7% to 9%, for example, you can assume that the patient would not respond to fluid administration. It is important not to give fluid to this patient. And it is very helpful in the absence of cardiac output monitoring because you need only an arterial line, no cardiac output monitor to use this test. And in COVID-19 ARDS patients is very helpful because these patients in general are ventilated with a low tidal volume. These patients in general receive a high doses of sedative drugs, for example, and PPV can be well interpreted in this situation during the tidal volume change. And the expert occlusion test, it is another test consisting in interrupting the ventilator for around 15 seconds at the end of expiration. And this provokes an increase in venous return and preload. And you can consider that it is like a preload challenge. And you can identify fluid responders by patients who increase their cardiac output during the test, a very brief test of 15 seconds only. And this meta-analysis with Francesco Gavelli, Xavier Monet, and others, we pooled 13 studies that all addressed the issue of prediction of fluid responsiveness by the expert occlusion test. And we found a very good summary around the ROC curve 0.91, good sensitivity, good specificity, and threshold value of 5%. It is very helpful in patients with ARDS. As you can observe in this category of patients with low compliance of the respiratory system, the effects of end-experience occlusion on cardiac output well predicted fluid responsiveness compared to pulse pressure variation alone. And again, in my experience, it is very helpful in COVID-19 ARDS patients. There is an important limitation of this index-respiratory oxygen test is that the patient should not interrupt the test by triggering the ventilator due to inspiratory efforts. And this may happen in 22% of cases if we refer to this study we published 12 years ago now. Passive leg raising test, you know, this maneuver consisting in moving the bed of the patient, and this maneuver is able to transfer blood from the legs and the abdominal compartments towards the intrathoracic compartment, and this maneuver mimics fluid challenge. But unlike fluid challenge, no fluid is infused and the effects are reversible. Of course, we need to assess the hemodynamic response to passive leg raising, which can predict the hemodynamic response to volume infusion. The advantages of passive leg raising first is to provide a good prediction of responsiveness, and this is confirmed by this meta-analysis we performed with Xavier Monet and Paul Merrick, where we included 21 clinical studies, almost 1,000 patients, and we showed that the changes in cardiac output during the PLR test well predicted for responsiveness with an excellent area under the ROC curve and threshold value of 10%. Another advantage is that unlike fluid challenge, the effects of passive leg raising are rapidly reversible. And this is what we found in this study we published with Thierry Boulin and co-workers in my unit almost 20 years ago now, and we measured right atrial pressure and POP using a Swengon catheter before, during PLR, and just after PLR. And after PLR, all the values of right atrial pressure and POP return to the baseline values. Therefore, the effects are rapidly reversible and there is no risk of pulmonary edema, for example. Another advantage of PLR is that it well predicts fluid responsiveness in situations where PPV fails to do it. For example, during spontaneous breathing activity. This is another study we performed in my unit with Xavier Monet and others. We looked at patients with spontaneous breathing activity while mechanically ventilated. And we assessed fluid responsiveness using pulse pressure variation. As you can observe, the ROC curve is not satisfactory enough to predict responsiveness, but the effect of passive leg raising on cardiac output well predicted fluid responsiveness in this specific category of patients. Also, in patients with low lung compliance. Again, this study we performed in our unit some years ago, where we looked at patients with low respiratory system compliance. And again, the effects of passive leg raising on cardiac output well predicted fluid responsiveness with an excellent area under the ROC curve compared to PPV alone. And also, it is very helpful in COVID-19 ARDS patients. Of course, there are some limitations or some constraints to use passive leg raising. For example, we need to avoid sympathetic stimulation during the test to avoid misleading interpretation. This is why we need to move the bed, not the patient. We should not stress the patient. Emotional stress, for example, which can produce some sympathetic stimulation. So we should monitor heart rate. If heart rate does not change or does not increase during the test, you can think that sympathetic stimulation is not so marked, and therefore you can interpret the test. Another constraint or limitation is that you cannot use the response of arterial pressure, and you should monitor cardiac output but not arterial pressure during the test. And in this meta-analysis, I already talked about, we also looked at the change in arterial pressure, systolic arterial pressure or pulse pressure. And we found an area under the ROC curve of only 0.77, which is good, but not satisfactory enough. In particular, we found very frequent false negative cases. Patients who increased cardiac output but did not increase systolic arterial pressure or pulse pressure. But we can use a change in arterial pressure variation during the test. And this is what is new. Some weeks ago with Temistok Takeri, Xavier Monet and others from my unit, we showed that a decrease in pulse pressure variation during passive leg raising is reliable to predict fluid responsiveness. So if you have no cardiac output monitoring device, arterial line only, you can look at the change in PPV during PLR to predict fluid responsiveness. And again, very helpful in the absence of cardiac output monitoring device. Also, another paper which is on the website of British Journal of Anesthesia, not yet published, with Olfa Mzawi and others, we also showed that the change in pulse pressure variation with PLR can predict fluid responsiveness reasonably in patients who are mechanically ventilated but with persistent spontaneous breathing activity. We cannot use the changes in CVP during PLR to replace the change in cardiac output. This is what we found last year with Olfa Mzawi and others. We showed that the changes in CVP during PLR cannot predict fluid responsiveness. But we need a real-time hemodynamic assessment during PLR because the effects of PLR are very transient. They can disappear before the end of the maneuver. So we cannot use, for example, transpulmonary thermodilution or pulmonary thermodilution to assess hemodynamics during passive leg raising. And finally, intra-abdominal hypertension is an important limitation. And this is what we found 2 years ago with Alexandra Burton, Xavier Monet, and others. We included patients without intra-abdominal hypertension and patients with intra-abdominal hypertension. In patients without intra-abdominal hypertension, we found that the effects of PLR on cardiac output very well predicted fluid responsiveness. But in patients with intra-abdominal hypertension, we found a very poor ability of PLR to predict fluid responsiveness, essentially due to many false negative cases. My conclusion, in patients with shock despite initial resuscitation, it is important to assess the volumic status by testing fluid responsiveness as often as required, since fluid responsiveness is a dynamic phenomenon which can evolve over time. Today, we have many reliable dynamic tests to do this. But even in case of fluid responsiveness, it is very important to assess the benefit-risk ratio before fluids or fluids administration before any infusion, especially in patients with associated ARDS. So we should assess the benefit, which is the degree of fluid responsiveness. For example, if you have an increase in cardiac output during PLR of 12%, the response you can expect is not so high. If you have an increase in cardiac output of 25%, you can expect a very positive response of fluid administration. So the degree of fluid responsiveness should be assessed, but the risk of fluid infusion also should be assessed by some indices of lung tolerance, like the PF ratio, the value of extravascular water, the value of POP if you use a Swengan catheter, the presence and the number of B lines if you use lung ultrasounds, etc. Now I would like to thank you very much for your attention.
Thank you very much, Doctor, once again. Dr. Jean-Louis, we have a couple of questions that we would like to ask from our audience. And now the first question, once that you have passed resuscitation, do you consider that there is a group of patients that would benefit from fluid, additional fluid, in spite of having some predictor or having measured a volume predictor that is negative?
Well, first, if the patient is not fluid responsive, I think my profound belief is not to give fluid, because we cannot expect benefits from an increase in cardiac output, sufficient increase in cardiac output to improve the situation, to reverse shock, for example. And therefore, any drop of fluid in this situation would have some risk. For example, if you give fluid in non-responders, of course, you can have an increase in the cardiac filling pressures and the risk of edema, but also you can create some hemodilution. Hemodilution, you have a decrease in hemoglobin concentration. If you have no increase in cardiac output and a decrease in hemoglobin concentration, oxygen delivery decreases, which is not the goal of resuscitation, of course. So I do not recommend to give fluids in patients who are not fluid responders according to the test you use.
Thank you very much, Doctor. Fully agree. The other question that we wanted to ask, do you believe that the volume predictor test to know in which part of the curve the patient is in the Stark-Stallinger curve, could that be useful to guide the descaling therapy for fluids, like using diuretics, or those patients that in renal therapy, the use of filtration? Will this have a role or already has an established role?
Yes, this is right. We also can use the fluid responsiveness test in the other side for descalation, for the decision of fluid removal, using ultrafiltration, using diuretics. So if the patient has some, I would say, some edema, lung edema, and is not fluid responsive, this is maybe time to think about fluid removal. And there is no risk of fluid removal in this situation. And you can use ultrafiltration, hemofiltration, for example. In a study we published some years ago in our unit, we showed that fluid filtration, hemofiltration, and ultrafiltration can have no effect, deleterious effect, if you are fluid unresponsive. But if you are fluid responsive, you can have some, for example, intradialytic hypotension. Only fluid non-responders had no hypotension during dialysis and during hemofiltration. So this is another way to use the fluid responsiveness test. I would call the fluid non-responsiveness, unresponsiveness test in this situation.
Thank you very much, Doctor. These are the only two questions for this section. We're going to move on to the next section.
Thank you very much.
Doctor.
Thank you.
La presión de conducción o driving pressure se calcula como la diferencia que existe entre la presión meseta, medida con sosteniendo o reteniendo la inspiración brevemente, y la presión expiratoria terminal o final, que sería lo que se conoce como PEEP. Entonces, esto es lo que sería la P. Sabemos que la distensibilidad pulmonar se calcula
volume in the lungs over the driving pressure, or the difference between the plateau pressure and the PEEP. When tidal volume is held constant, driving pressure becomes purely a reflection of changes in lung compliance, assuming there's no change in chest wall compliance between measurements, which is usually not the case. Despite having altered chest wall and abdominal compliance in our ICU patients, when we're at the ventilator making adjustments over a short period of time, chest wall compliance or abdominal compliance is really not going to change. Driving pressure and pleural pressure, we're always, as Professor Goligher pointed out on numerous occasions, it's the transpulmonary pressure that we are primarily interested in, because that's the lung compliance piece. It's also the contributor, the primary contributor for ventilator-induced lung injury. But again, despite the fact that pleural pressure may be significantly higher for any given tidal volume in patients that are obese, have anasarca, increased obesity, the change in the driving pressure will reflect changes in lung compliance, assuming that the chest wall or abdominal condition does not change. So on this slide, what you see are a variety of airway pressure volume curves. You see volume plotted on the y-axis, airway pressure on the x-axis. And you can see that on the lower parts of these abnormal curves in ARDS patients, that you don't get much lung inflation until you reach higher pressures and you begin to open up lung. Likewise, there's an area where compliance is better, and then as you begin to overinflate lung, it flattens out again. So this steeper part of the compliance curve, of the pressure volume curve, is where our compliance is good. If you think about Peep setting, Peep does two things. It recruits lung that was previously closed or poorly ventilated, and that's good, and that improves compliance. And by using the same tidal volume as we typically do, we choose a tidal volume, let's say 6 mLs per kg. We stick with that tidal volume, and as we change the PEEP, the driving pressure becomes a reflection of the average of overdistension as we increase the PEEP and recruitment. And therefore, the PEEP that gives the lowest driving pressure would give the best balance of recruitment and overdistension, and would seem to be a reasonable way to set PEEP. Fixed tidal volume in ARDS, the lower the driving pressure with PEEP adjustment, the better the compliance. And as Professor Goligher pointed out, there's very good data that lower driving pressures in ARDS are associated with decreased mortality, with the best cutoff point being 13 to 15 mLs per centimeter water or lower. I would say that you never can have too low of a driving pressure as long as your tidal volume is chosen to give adequate ventilation for that patient. Lowering of driving pressure in response to PEEP also is indicative of better outcome. The implication there would be that there is recruitable lung, which would, from a prognostic standpoint, be better. So yes, I tend to use driving pressure as an important variable when I set PEEP at the bedside. However, I realize that from an evidence-based medicine standpoint, that setting PEEP by driving pressure is less clear from an evidence-based medicine standpoint. I just went over the chalkboard logic with you, and that's clearly there. There's no prospective study using driving pressure to set PEEP that shows clinical outcome benefit. There is one study that used compliance, which would be the same as using driving pressure, to set PEEP and actually showed worse outcome. However, this trial used a very aggressive recruitment maneuvers, which may well have been the reason that this particular protocol did not show benefit. Driving pressure of 13-15 would be a reasonable target with PEEP setting. The lowest driving pressure at a fixed tidal volume gives the optimum balance of recruitment and over distension. Now I'm going to move on to the second part of my talk, dealing with the recruitment to inflation ratio. Does my ARDS patient have clinically significant recruitable lung? I think all of us have been in a situation where we had an ARDS patient. We saw it a lot with COVID. And in a particular patient, we were unable to use ventilator maneuvers to recruit lung. That patient, for whatever reason, met ARDS criteria, but did not have clinically significant recruitable lung, which is very disturbing. And as I mentioned earlier, from a prognostic standpoint, is also not good. So what I'm going to show you is a very simple single breath technique that will allow you to predict whether your patient has clinically significant recruitable lung. And it's called the recruitment to inflation ratio. It's defined as the compliance of what is called the recruitable lung at 2 settings of PEEP, and that's the tricky piece, and I'm going to go over that in great detail, over the compliance at the low PEEP setting. So we use data gathered at a higher PEEP, typically 15 centimeters of water, and a lower PEEP, typically 5 centimeters of water, plus the volume measured during an exhalation release from end inspiration at 15 PEEP to 5 PEEP. Now don't let that scare you, because I'm going to walk you through this very carefully. The recruitment to inflation ratio seems to perform well in predicting whether the patient is PEEP responsive, with values of equal to or greater than 0.5, signifying clinically significant recruitable lung. So we're going to use an example so I can calculate it for you and show you the essential components. We're going to use a PEEP of 15 for our high PEEP setting with a set tidal volume of 400. And we're measuring an exhale tidal volume of 398. We're going to use a low PEEP setting of 5, again with a tidal volume of 400. We're going to measure the plateau pressure on the low PEEP setting, and that's going to be 17. That allows us to calculate the driving pressure at low PEEP, which is 17 minus 5, which is 12. And we'll divide the tidal volume of 400 by the driving pressure of 12, giving us a compliance at the low PEEP setting in this ARDS patient of 33 mLs per centimeter of water. So we have the denominator. So we already have our denominator value, which is 33. So now we just need to calculate the numerator value. And that's a tricky piece, as I mentioned. And we're going to use something that's very simple and automated to do on a ventilator. I'm going to show you with an example on a video. But what we're interested in doing is, here's a patient that it is on a PEEP setting of 15. Our patient here, you can see the pressure, PEEP of 15. Here's our tidal volume set at 400, giving 398 exhale tidal volume. Here's that exhale tidal volume here of 398. And then at the end of inspiration, for the exhalation, we're going to drop the PEEP to 5 from 15. So we drop the PEEP by 10. And now when we measure the exhale release volume, it's going to be a total of the tidal volume delivered at 15 of PEEP, which is here, and the volume that's lost from the lung going from a PEEP of 15 to 5. So the end expiratory lung volume drops by that 10 centimeters of water decrease. And here I'm showing you, this is the exhaled release volume with this first bracket. That's all the way from the end of inspiration here to the end of expiration. And we're going to subtract the tidal volume of 398, and that will give us this volume that was produced by the drop in PEEP from 15 to 5. And let me show you an example of that here. So what you're going to see is that this plateau pressure, once the PEEP is dropped to 5 and the tidal volume stays at 400, you'll see that plateau pressure go to 17, which was the plateau pressure we used to calculate the compliance at the low PEEP. So here you saw the 398, or it's around 400, and then the exhale release volume here was 818, and that's the value that we'll need for the calculation and I'll show you that. So this is something I created to show you how we're going to calculate the compliance for the recruitable lung between the 5 and 15 of PEEP. Here's the exhale release volume of 818 here in yellow. Here was our exhale tidal volume of 398 at 15 of PEEP. If you subtract 398 from 818, you get 420. So when we dropped our PEEP from 15 to 5, we decreased our end expiratory lung volume by 420, which means that the PEEP at end expiration, as we went from 5 to 15, gave 420 mLs of additional lung volume. And if we take our compliance at a PEEP of 5, we would predict that that 10 increase from 5 to 15 would have given 330 mLs of increased volume going from 5 to 15 pressure, but we got 420. So the additional volume, or the recruited volume, was 90, and that's the value we're going to use to calculate compliance of this additional volume. And here's how we do it. We take that 90, the above the predicted increase going from 5 to 15, divide it by the drop in pressure, or the rise in pressure, of 10. So that gives a compliance of 9 mLs per centimeter of water. Then we put the 9 over the 33, 9 here on compliance of the recruited lung over the compliance at 5. That gives a 0.27 RI ratio, and a 0.5 or more predicts clinically significant recruitable lung. So in our patient with our RI ratio, we would predict that this patient is not going to have clinically significant recruitable lung. Theoretically, values can be anywhere from the value we have here on up to 1 and greater than 1. Now, a lot of you were saying, well, Dr. Dellinger, I think you understand that, but I'm never going to understand it, or at least not in the foreseeable future. And there is a website that calculates it for you. You put in the following values. You put in the high PEEP. In our case, it was 15, the set tidal volume 400, exhale tidal volume 398, low PEEP 5. This was our exhale volume from the high to low PEEP, and from end inspiration at high PEEP to low PEEP. And here was our plateau pressure at low PEEP. And you can see it calculated the same result. You just, it's not as satisfying as calculating it. But certainly this is available. You can see this is the Toronto Critical Care ARDS mechanical ventilator website. There's one caveat. There is a group of patients that you can't use this on. We now recognize that in ARDS, like asthma and like obesity, there is airway closure at end expiration, and this may be very significant, such that when you initially initiate inspiration, it takes a considerable pressure to open up lung to create flow into the lung. Here you can see patient B has no airway closure. You can see as soon as the pressure went positive, there was immediately this rise in lung volume on this model. Whereas in this patient, patient A, this increase in volume reflects expansion of the circuit. And it's only when you hit a pressure of 15 that you begin to fill the lungs. You see it here again when the PEEP is set at 8. And it's not until you set the PEEP at or above the 15 that you see lungs filling. So if your airway opening pressure is more than your high PEEP, this calculation and this RA ratio will not work. This is very easy to do. Most ventilators is automated. You just use a very low inspiratory flow rate. You can see how low it is here, but it's like 5 liters per minute. You get a nice curve, easy. No high PEEP needs to be higher than airway opening pressure. So in summary, role in management of ARDS, driving pressure. If you heard Dr. Goligher's lecture, you saw that it is very useful for choosing tidal volumes. It may be helpful for setting PEEP. I use it, and the recruitment to inflation ratio has been shown, and we didn't go over that piece, but how do we know that a ratio of 0.5 or greater reflects clinically significant recruitable lung? We know it from sophisticated hysteresis curves in the same patients that had the recruitment to inflation ratio and also ultrasound. Thank you very much. Muchas gracias.
Hello, good afternoon, Dr. Dellinger. First of all, I would like to thank you for your presentation. This is an extremely interesting topic for all of us, and it seems to be that we have time for just one question. This question has to do with that recruitment inflation ratio. When would you recommend to measure this ratio, and what's the interpretation we should assign to that? I mean, if the result is positive in terms of recruitment potential, could we use a higher PEEP or carry out a recruitment maneuver? I mean, what's the usefulness in doing that?
I think the usefulness is that right from the very start, when you first have an ARDS patient and you're going to set PEEP by whatever methods you use for setting PEEP, you can find out whether your patient has recruitable lung or not. So before, if you get a high value, then you want to put a lot of time and energy into finding what the best PEEP is to optimize that recruitment. And if you get a real low number, you probably don't need to spend a lot of time with that patient trying to figure out how you're going to optimize recruitment.
Very well, doctor. So once a patient has been intubated, we could measure it right away and then make a decision on whether to, well, I mean, if there's a higher PEEP or not, that would be justified or not. Thank you so much, doctor. We only have time for this one question, and now we will move to the next presentation.
Okay. Okay. Good morning. Good morning to everybody, and a good or good afternoon. Here in Germany, we are in evening. But I have to speak about mechanical ventilation and COVID-19 pneumonia. And I think in the next 20 minutes, I will try to put my view of the problem, which are not really very similar to the view of many other speakers. I have some view a little bit different, but I just to present my evidence, and I think you can judge or you can understand what I mean. Let's see. Mechanical ventilation is strictly linked with the patients that we have, to the condition of the lung of the patient. And what we learned over the decades about mechanical ventilation and the ARDS is relative to patients who come in the hospital, most of them with pneumonia, most of them with sepsis. These two etiologies cover about more than 80% of the patients with ARDS. If you take our big randomized trial, from which we investigate the PEEP, from which we investigate the mechanical ventilation, the tidal volume, etc., you go and look at the kind of patient we treat, you see that 80% of the patients have these two etiology, okay, which are pneumonia, sepsis. Then we have some inhalation, some vaginal disease, some vascular disease, and so on. All of these etiology, but remember, 80% pneumonia and sepsis lead at the end of the story to an inflammatory edema, When we have an inflammatory edema, we start the lung start to become wet as a sponge, which start to be full of fluid. When we have fluid in the lung, the gas space is decreased and the lung becomes heavy. When the lung becomes heavy, we have some compression of some regions, the dependent regions of the lung. So at the end of the story, we have a small ventilable lung. Of course, this has consequence on gas exchange, inlet mechanics, and the hemodynamics, because we have to pump the blood through this compressed and atheretatic, in part consolidated lung. Now, this is the classical ARDS. You see in X-rays, you have bilateral infiltrates, and if you take the CT scan, you see that most of the regions in most of these patients are in the dependent regions of the lung. In classical ARDS, how can I have an idea of the size of the baby lung? So how much is ventilable? I think we have a good system, which is the compliance. Because when our compliance, let's see, just to simplify the thing, let's take an adult patient, supine, 70 kilos, the compliance is about 80. If I take out one lung of this patient, the compliance becomes about half, about 40. If I have 20 compliance, means only about 1/4 of the lung, 20% of the original lung is open to the ventilation. So when you have the ventilator and you see the compliance, most of the ventilators display the compliance, you know which are the size of the battlefield in which you deliver your mechanical ventilation. In that small part of the lung, which has to support the respiratory burden of a patient, big patient of an adult size. Now, here we have a density in supine position, and this was the baby lung. Now, if I remember, I'm speaking about the ARDS primarily from bacterial pneumonia and from sepsis. So peritonitis, pancreatitis, etc., etc. Now, if I take this patient, I put in supine position, you see that the density goes down. The dorsal regions clear up, and the baby lung is not more up. How is in the dorsal part? So the baby lung is a dynamic concept. It's not an anatomical, precise concept. So the lung is a big sponge which compresses, when it gathers edema, compresses the regions down here. When I put the patient in prone position, I change the gravitational application, I open up here and I close down here. And this is the prone position. When I put PEEP, I nothing else than I try to overcome the problem of the lung weight. If my pressure here is 10 centimeters of water, if I put 10, this one remains open, but this one will be over-distended. You like or you dislike, PEEP is always a compromise. Don't believe when you read, we find an optimal PEEP to keep open the lung without over-distension. This is physically impossible. It's simply not true. Now, in this panorama, what the COVID had taught us, as soon as the COVID appears the first way, I think most, a great majority of the people say, okay, this, have we bilateral infiltrates in the lung? Yes, because you have ground glass and so on. We have hypoxemia. Oh my God, we have a lot of hypoxemia in talk. So this is an ARDS, and we know how to treat the ARDS. I have to have the small lung volume. I go and take the PEEP and file to Teboul. I start to apply, I come out with 15, 20 of PEEP in this patient. But is ARDS, let's call it ARDS, from virus disease as COVID, similar to the ARDS from which our knowledge has been derived? That means bacterial pneumonia and sepsis. This is the very first patient we had, in which first observation we had, we look at the patient, the compliance, about 50%, these are very few patients, about 16 patients, but they are equal. We are not a syndrome here, we have a disease. So I don't need 2 million of patients to understand what's going on. 2 patients or 3 patients tell me exactly what 2 million of patients tell me in terms of pathophysiology, in terms of mechanism. And you see that about half of the patients here have a compliance greater than 50, 60, 70, 80, which is normal, near normal. But this patient had together and a right to left shunt fraction greater than 30. Greater than 30, you cannot have a normal PO2, even if you use 100% oxygen. So what was striking, because I studied ARDS since the decades, I never saw so many patients with this huge dissociation between lung mechanics and gas exchange, more than gas exchange when the oxygenation. And now this is recent, still unpublished, a paper, but look, this is a series of patients very early. Remember, the time of observation is crucial to understand this disease. These are patients just arrived in the hospital, all had a CT scan, all had an esophageal balloon to measure the esophageal pressures, all went consecutively in a high dependence unit, not still in intensive care. And you see, some of them had a PO2 greater than 350, so they were not ARDS. Here you have the lung weight and the non-inflated tissue. You know that the total lung weight is about 1.1, 1.2. In severe ARDS is about 1.7, 2, 2.5, almost double. But you know, here, the patient here, 300 PO2, this lung weight, here patient with less than 50. The CT scan, true, mild, moderate, severe, here is under 50 of cutoff. You have beautiful degrees in PO2, and all these patients had exactly the same CT scan. That means that the mechanism of the true atelectasis and the right to left shunt is not operating. The mechanism of hypoxemia has nothing to do in this patient with the problem we had with patients with bacterial pneumonia and with sepsis. You may like or you may dislike, but gas exchange is mathematics. So you have a lung which is full of gas, with the lung is flexible, the compliance is good, and the PO2 is terribly low. We have only one possibility, is the problem of perfusion. And you don't cure the perfusion with PEEP. And this is the compliance on the x-axis, and here we have the compliance here, and here below we have the gas volume. And you see exactly what we found 40 years ago, the same thing. When the compliance is high, means the gas volume is okay. It's quite simple. Look here, these are patients with the same PO2 matched for a PF. These are the patients close to the sternum. The lung is divided in 10 regions, close to the sternum, middle lung, paravertebral. This is the amount of gas. You saw in each little piece of lung, the gas was almost double in COVID pneumonia than in bacterial pneumonia, with the same gas exchange. Now, to me, it's extremely difficult to understand how so many of my colleagues do not recognize this, because the patients are the same. Of course, if you look at the patient, not at the beginning, but after 2 months or after a month, the game is completely changed. So at the beginning, when the patient arrives in the hospital, the great amount of patients have sometimes a flexible lung. Many of them are not dyspnoic, are terribly hypoxic, and they have inflammation endothelium, and the problem of gas exchange is here, with the loss of vasomotor zone and vacuum mismatch. Here, let's see, if the patient in classical ARDS, if you look at the perfusion, in classical ARDS, these regions, white, is under-perfused because we have hypoxic vasoconstriction. In COVID, look here, these regions is hyper-perfused because you have lost the hypoxic vasoconstriction. Now, look here, what is black. You say, okay, oh, this is a very good lung. Perfusion is 0. This is called VAQ maldistribution. Ventilation goes in one side, perfusion goes in another side. Response to proning and recruiting. Look here. This is a patient with supine 5, and you see wide lung. This is very similar to LDS. PO2F 88, okay? This is a patient with the same patient, which is put in prone position. And you see, as in LDS, the density goes down, tends to go down. And here are the patient, the same patient with 35. You see a beautiful recruitment, 39.9. And recruitment, I mean recruitment measured with the CT. All the gas method to measure the CT, the ratio and so on, they do not measure the recruitment, only the recruitment. It's a mixture of other characteristics. And the results of a CT and the gas methods are completely different sometimes. So be careful to assume as a recruitment whatever measurement in gas. But look here, we have this patient 80. I'll put in prone position, nothing happened. I put a recruitment 35, the 0.1. These are 2 patients with COVID. What is the difference? The difference, my dear friend, is the time. This is quite early stage. This is far late stage. You don't see a patient like this at the beginning. Now tell me, in a patient like this, as an example, if I use a very high PEEP, what do I do? The FPF is 80. Here is 80. In about 50% with high PEEP, the PO2 decreases when you are in this condition. You cannot treat this patient without understanding how the lung is at that moment. It's extremely important to look at the time. And the problem is that the lesion here are mainly edema and atelectasis, here are fibrosis. You cannot discriminate. The poor CT tell you the density, the ratio between the gas and the volume, but doesn't tell you the nature of the mass. The mass might be water, might be lung tissue, might be blood, might be fibrotic tissue. To have an idea, you have to take the CT scan in different pressures. So what is openable means it's atelectatic. What is not openable is usually fibrotic. And here is an example in prone position. If I put a patient, let's say I have 2 extreme examples, not a mixture. An extreme patient I have only atelectasis, mean all interstitial edema, lung weight, compression, atelectasis. I put in prone position, I just have this open up and this part close down. When we have consolidation, I put this one, stay up, and stay up, because I not move. Because consolidation means this is or fibrotic, or the pulmonary units are full of something. You can put the pressure you want, you don't open up. So the concept of opening, how much of openable the lungs I'm treating in this moment. So, this has to tell you that to have a rational indication to the mechanical ventilation, you have to take into account the time. When we published this, the people, a lot of my distinguished colleagues were completely upset. And to me, it's difficult to understand how it's impossible not to see that at the beginning, the patient comes with low elastance, that means good compliance. Low VQ mismatch is the cause of the hypoxemia. The lung weight is pretty normal, and the recruitability is very low. When you don't have recruitability, tell me what to put IPEEP. You just hyperinflate the lung. You just have a hemodynamic problem. You just push the kidney in a bad condition. Now, if the patient continues to very strong respiratory effort, because this is one of the problems of COVID, you may have a self-induced lung injury. And that means you have to be pay extreme attention how the patient breathes when you treat, as an example, with non-invasive support, CPAP and so on, which is the right approach, I think, at the beginning. But after you have implemented the approach, you don't have only to look at the PO2. You have to look at the patient. How much is the cost of this PO2? If the patient continue with a high rate, he continue with inspiratory effort and so on. If they have this, it's a problem. Look in the second way, how many patients come from home with pneumomediastinum, with pneumothorax, an amount that I never saw before in a normal ARDS. Because this patient have this tremendous inspiratory effort. Of course, with the inspiratory effort, they start the normal ventilatory new lung injury, that means edema. So maybe the patient come in intensive care, you have to put the tube perfect. You put the tube, I mean, you take the looks aseptic because very high pressure, very high low pressure, maybe not great pressure and so on. I mean, problem to give 1-2 liters of fluid. You look at the protocols, you say, okay, give fluid, and this, you give fluid, all this fluid goes in the lung. You have a disaster during the intubation, and you start to, at this point, you have edema, and you have big edema. And if you continue like this, you are right to transform this edema in fibrosis. And at this point, you have the classical late ARDS, in which you have low recruitability, more than high recruitability is in an intermediate state. At the end, we have low recruitability, PCO2 goes up, and the only thing that you have to do is to wait to pray or the transplant. So, and I'm going to conclude. At the beginning, I mean, non-invasive support, if effort persists, consider the mechanical ventilation. At the beginning, when the patient is mechanically ventilated, FiO2 is okay, tidal volume, even if you use 8 of tidal volume to prevent hypercapnia, look at the plateau pressure. The plateau pressure is below, sometimes below 20. Why do you have not to be worried about the VILI in this patient? The VILI is more frequent, is more risky in spontaneous breathing of this patient than during mechanical ventilation. And the PEEP, please be careful with PEEP, with low PEEP. Prone position will improve the PO2, but we do not have the prerequisite for improve the, and it has not been shown particular improvement of of outcome. Anyway, prone position, in my opinion, whatever you do bad to the lung is less bad in prone position than in supine, because stress strain is distributed more evenly. Of course, when you have a patient like this, like ARDS, you just apply what we learn with the other kind of ARDS. But please don't do that at the beginning. I don't ask you to believe me, but I ask you to consider and start to think, and overall to start to measure. If we do not measure and we take just the protocols and the table, or just measure the PF, the risk for the patient, I'm afraid, are extreme increases. So, and this is my last slide. If you want, let's see. You can see it. Well, maybe you can see it. Atelectasis, no at the beginning, in intensive care goes up, and then become fibrosis. PCO2 goes up, and that space increases with time. That means structural changes of the lung. Compliance, very good at the beginning, going down progressively. Oxygenation stay pretty constant, very bad, but the mechanisms behind are likely different at the beginning and in the late phase. I thank you for the attention. Okay?
Hello, Dr. Luciano. It's a
Hello?
pleasure for us. We wanted to see if, first of all, we want to thank you for your presentation. And aside from that, we would like to ask if we could pose a couple of questions that we are getting from our audience in regards to your presentation. The first one is, given that, according to what you have commented, the time elapsed since the moment that a lung injury starts is very important in terms of the mechanics of the lung, and also in the recruitment potential or recruitment potential that the patient might have. And given the fact that this can be in types H, if the lung is recruitable, and if the lung even is in a fibrotic stage, how much time would be reasonable to consider that the patient could have changed from one of the stages to the other one, so that we can guide our strategy for ventilation according to the mechanics of the patient in this regard?
Well, okay. When we have a patient as an example, after 2-3 days, when after the patient is, let's say, in non-invasive support, you immediately can see what is the trend, the trajectory of the patient. The patient we had, they reach a status of mechanical ventilation. That means the patient are very bad in spontaneous breathing. Let's see, 20% of the patient. It takes about 6 days. Let's see, within 1 week. But the first sign you have quite after 2-3 days. If you don't have any improvement, you realize that it's possible that this patient goes along the bad way. Then, in intensive care, the transition between atelectasis and fibrosis, I think it takes is something about 7 to 10 days. This is an order of magnitude. So to have the tremendous, when the lung is become a piece of wood, not recruitable, PCO2 out of control. So with all the characteristics of the late ARDS, this takes usually more than 2 weeks. In the 3rd week, you have this kind of picture. So if you take the week as a possible of early, intermediate, and of course, this is just to have an idea, okay? Then the single patient may be made a little bit change.
Thank you very much, Doctor. I think we have time for another question. And there is another one that is very interesting coming from our audience here. Your opinion, Doctor, about what is the future of the ventilation strategy in open strategy. Is it worthwhile to continue studying this refutable phenomena of recruitment in some patients? And what is your opinion about these groups that use non-conventional ventilatory methods, APR, that are based on recruitment, to take advantage of this theoretical benefit that we still do not know very much how to use
I don't know
in the
if I
patients that have severe ARDS?
You know, recruitment is part of the characterization process that you have to do in that particular patient. In that particular patient, we have to measure the thing. Or at least, as an example, we do at the beginning the CT scan. We do the CT scan at two pressure, one at 5 centimeter water and expiration, and the other one in COVID at 35 centimeter water because of the risk of pneumothorax, in normal RDS at 45, and you immediately see what kind of how much of the lung is open. I know that the ratio, the compliance ratio of the system which are introduced at the moment are all based on variation of gas exchange. They tell you something that is called recruitment, but we are not speaking about the same thing. If with the recruitment you mean opening of units which were before closed, the only way to measure is the CT scan. The ratio, the volume pressure curve to volume pressure curve, measure something else. They measure also the amount of gas which enter in units which are already open. And you look at the same patient, you measure in one way, or you measure in the other way, you have a completely different results. In one patient, you see with a CT scan, maybe the amount of gas recruited is 50 milliliters. With the other system, you found 500 milliliters. And you know, this is to use the word, the same word, for different reality. But to understand the reality, you have to measure. And during this COVID disease, for almost 1 month, nobody was took a CT scan of this patient. That means was CT scan and one gas exchange was enough to understand that something with the gas exchange mechanism is wrong compared to the RDS. I don't need 2 million of patients because we have one disease. So the story, the real thing that we have to do with this patient is not to add damage to damage, because we don't have the miracle system. So we have to use the stress and the strain as low as possible, and to keep the patient quiet and hoping that his natural resources may win. We don't save any life with mechanical ventilation. We buy time. We have to buy time without damage. So the question is, to have a PO2 120, the damage is more than having the PO2 of 80? Sometimes yes, but the cost of 120 doesn't mean anything. You do not cure the PO2. We know since the ARMA trial that the patient with lower PO2 were the patient at the end of the story who survived better. But we have this paranoid and Pavlovian reflex. Low PO2, I PEEP. Low PO2, I FiO2. PO2 goes up, yoo-hoo, this is recruitment. Forgetting little thing as the gas exchange and the perfusion. To look at the PO2 without thinking to the perfusion means a complete ignorance of the basic physiology.
Thank you very much, doctor, for your answer. And we will close this question and answer session for your presentation. We thank you so very much, and we will continue on with the next presentation. Doctor, thank you.
Thank you. Thank you to everybody.
Good afternoon. I'm Janice Zimmerman, and it's my pleasure to be here for this 24th International Forum of Critical Care. And the topic I wanted to review with you today is not about the lung, it's about thrombotic thrombocytopenias, particularly heparin-induced thrombocytopenia, vaccine-induced thrombotic thrombocytopenia, and even a little bit more. I have no conflicts of interest related to this topic. So the three conditions that I want to review with you, of course, first is heparin-induced thrombocytopenia, and then a condition called autoimmune or spontaneous heparin-induced thrombocytopenia. And I hope as you'll learn that that's a very inappropriate name for that condition. And then last, the vaccine-induced thrombotic thrombocytopenia associated with COVID vaccination. By the end of this, I hope to convince you that a better name for these conditions is actually immune thrombotic thrombocytopenias mediated by platelet factor 4. So let's start with heparin-induced thrombocytopenia. This occurs, of course, with all heparins when they're exposed. We know it occurs more commonly with unfractionated heparin than low molecular weight heparin. And we see a typical evolution of this condition. Usually patients present with thrombocytopenia 5 to 10 days after exposure to heparin, the median being 6 days. Also, if they've had a prior exposure to heparin in the preceding 3 months, this may occur much earlier. By 8 days, we see the platelets have decreased to greater than 50%. And if they're going to develop thrombosis, we'll usually see that a median of 10 days after heparin was started. In general, with heparin-induced thrombocytopenia, it's a moderate thrombocytopenia, with the average level being about 40,000. And you don't often see values as low as 10 and 20,000 in this condition. Now, I'm going to spend a little bit of time talking about the mechanism, because as you see, we'll use that same mechanism to explain some of the other conditions. First of all, heparin binds to platelet factor 4. Platelet factor 4 is a positively charged compound. Heparin is negatively charged. So this forms a heparin platelet factor 4 complex, and that heparin actually induces a conformational change in platelet factor 4. And due to that change in the structure of platelet factor 4, antibodies, an IgG antibody is developed and produced against that heparin platelet factor 4 complex, and that creates an immune complex of the antibody, heparin, and platelet factor 4. Now, what happens with these immune complexes, they form actually multimers on the surface of platelets, and they actually cause an interlacing cross-linking of these compounds with the Fc receptor on platelets. And although this picture has just one of these complexes, picture a platelet with many of these complexes on the surface. And what that leads to is activation of the platelet, also apoptosis, and also elimination of these platelets by the spleen. But you also have to remember that it's not just platelets that get activated by these immune complexes. These complexes also bind and activate monocytes, endothelial cells, and neutrophils. So you can see that this plays a role in the inflammatory response to many of the conditions we see, like infection or other traumatic events. Now, these antibodies and heparin-induced thrombocytopenia are a little unusual. There's not a typical sequential production of antibodies, starting first with IgM and then switching to IgG. And this suggests that there's some type of endogenous exposure that leads to IgG being present initially. Now, you can see all classes of antibodies, and they can all occur at the same time, but you can also see one or two, and not necessarily all three, but only the IgG antibody is associated with clinical heparin-induced thrombocytopenia. These antibodies disappear within 3 to 6 months after heparin exposure stops. And it's interesting that on re-exposure to heparin, you may actually not see these antibodies develop again. So usually the first suspicion of heparin-induced thrombocytopenia in your patients is a decrease in platelet count. But also, if you see the presence of a thrombosis in the presence of heparin, it should make you think about this, and the presence of unusual thrombosis, such as we're seeing with the vaccine-induced thrombotic thrombocytopenias. When do you discontinue heparin? While you're waiting on test results? Well, if your platelet count has already decreased to less than 50,000 or decreased by 30 to 50%, you'll see various recommendations. If they have thrombosis, and about anywhere from 30 to 80% of patients will develop thrombosis, rarely would you see hemorrhage. That occurs in less than 10% with heparin-induced thrombocytopenia. But these are all situations where you want to stop heparin while you're pursuing diagnosis. Now, the diagnosis of heparin-induced thrombocytopenia occurs in 3 steps. First step is looking at the risk factors in your patient and using a probability score or pre-test probability. So what are the risk factors? Well, these you also are probably familiar with. Higher risk in cardiovascular and orthopedic surgery patients, high risk in ECMO patients. It's more common in women than in men, and it's more common with unfractionated heparin than low molecular weight heparin and fundaparinux. We also know that the higher the dose, so therapeutic doses, more likely to be a risk factor for heparin-induced thrombocytopenia than prophylactic doses. Also, patients who are exposed to therapy for a longer period of time. And then we combine those risk factors with a probability score. There are really 3 scores out there. The most commonly used is the 4T score, and this is the score that's recommended by the American Society of Hematology. There are some limitations. It's less reliable in cardiac surgery patients, and you can see variability in how it's applied by different evaluators. So I would say that no single score or risk factor should dissuade you from considering the possibility of heparin-induced thrombocytopenia. There's also a heparin-induced thrombocytopenia expert probability score, and this was actually developed by people who are considered experts in this condition, but it's much more complex and it requires more time to calculate, and it has not been prospectively validated. So it's out there, you can look it up on the internet, but it's not commonly used. There's also a separate score for cardiopulmonary bypass patients. And this score takes into account the relation of the platelet count with the date of cardiopulmonary bypass and also the duration of cardiopulmonary bypass. Now, the next step in diagnosis of heparin-induced thrombocytopenia is an ELISA immunoassay. This type of assay detects the antibodies against the platelet factor 4 heparin compound. Now, these assays can be polyspecific and pick up all classes of antibody, or they can be specific for IgG. You might want to check with your laboratory and see which one you have, The one specific for IgG is considered to be better in that it is specific for the pathologic antibody. These antibodies in this test actually bind not to heparin, which is not used in the assay, but a polyvinyl sulfonate. That's important to keep in mind because this polyvinyl sulfonate is another negatively charged anion like heparin. As the measurement is often due to optical density, and many of these tests have a threshold optical density that predicts a very positive result for heparin-induced thrombocytopenia, and also predicts a positive result on a functional assay that we'll talk about next. That optical density correlates with the amount of antibodies present. So a higher number of antibodies gives you a higher optical density. Now, these tests have high sensitivity, but low specificity. So in patients, cardiac surgery patients, cardiovascular surgery patients, you'll find this test to be positive in up to 50 to 60% of patients. And we're also seeing this test positive in up to 10 to 20% of patients with COVID-19. So that's the limitation. So if you really want to know specifically that you have a pathologic antibody, the third, excuse me. Oh, forgot to mention, these are the rapid assays. So we talked about the ELISA assay. There have been several other assays developed that are more rapidly performed. And this could be gel particle immunoassay, a chemoluminescent assay specific for IgG, or a lateral flow immunoassay. And a meta-analysis did suggest that these have good sensitivity and specificity, but these are tests that actually can't be used when you're concerned about vaccine-induced thrombotic thrombocytopenias. So there are limitations to these tests. But the third step, the ultimate test in diagnosing heparin-induced thrombocytopenia, is a diagnostic functional assay. And these assays evaluate the ability of antibodies to induce platelet activation in the presence of heparin. So it detects heparin-dependent activating antibodies. So these assays have high sensitivity and specificity for diagnosing heparin-induced thrombocytopenia. Now, the problem here is that they are more expensive and they're not widely available in all hospitals. There's also not been good standardization of these tests from laboratory to laboratory. So the two types of assays for functional tests are the serotonin release assay and then the heparin-induced platelet activation assay. So let's just talk a little bit about the serotonin release assay, because this is probably the more commonly used and the one that you'll see referenced in literature. So in this assay, platelets are labeled with serotonin C14. They're incubated with the plasma from the patient and two different concentrations of heparin, a low dose consistent with therapeutic heparin doses in our patients, and a high dose of heparin. So serotonin is released at the low concentration of heparin when there are antibodies present that activate platelets. Now, this is also confirmed by the fact that with high doses of heparin, this high dose actually inhibits the release of serotonin when there's platelet activating antibodies present. So they have to have both a positive with the low dose heparin and a negative with the high dose heparin. Now, false negatives have been seen with some of these tests. So again, you have to keep this in mind with your patient. Now, the heparin-induced platelet activation test is a little simpler. It takes the plasma of the patient and add it to platelets in the presence of heparin. If it's positive, you have aggregation of platelets, but these tests have actually been found to be falsely negative when antiplatelet agents have been present in the plasma of the patient, such as ticagrelor and some of the other antiplatelet agents. So let's say our tests show we have heparin-induced thrombocytopenia. What do we do? I think you're familiar with this management algorithm. Discontinue heparin. You anticoagulate even if there's no obvious thrombosis because the risk is so high. The anticoagulant that you choose may depend on what's available to you. Argatroban is probably the most commonly used in the United States. Bivalirudin has also been approved, but primarily for use in percutaneous interventions, but it's been used off-label. Fundaparinux has been used, but it's not approved for that indication. And we've seen more reports of using direct oral anticoagulants. Although it's not approved by the FDA, the most commonly used one that you may see reported has been rivaroxaban. Warfarin should not be used until the platelet count returns to normal. The other part of managing is obviously to try to avoid transfusion of platelets and only consider that option when there's severe bleeding. You should also avoid inferior vena cava filters because these actually predispose to more thrombosis. Now that's the typical management that most of you have to use, and you don't have to consider other options. But there are other options for difficult cases that you need to be aware of, and you're going to see this approach used in some of the other conditions. So IVIG, this removes the antibody, binds and removes the pathologic antibodies. When should you consider it? Well, if you have clinical worsening while the patient's on anticoagulation, or you're unable to anticoagulate the patient. Plasmapheresis can also eliminate pathologic antibodies, and it's considered when there's a need for immediate cardiovascular surgery that requires heparin, and also when you're unable to use another anticoagulant, or that patient is worsening despite anticoagulation. Now, another less commonly kind of referenced intervention that's only more recent is the use of Congrelor, which is a reversible inhibitor of platelets. Where you'll see this reported is with cardiovascular surgery in patients who already have known antibodies to heparin platelet factor 4, but they have to do surgery and they have to use heparin. So keep that in mind. It's going to be more likely used in surgical patients. Now let's talk about another condition that's often been referred to as spontaneous or autoimmune heparin-induced thrombocytopenia. That is totally inappropriate name, but that's what it's been. So many of you may have sometimes seen a patient where you thought they had heparin-induced thrombocytopenia, but they were never exposed to heparin. So they may have this condition. This is where they usually present with thrombosis, and the thrombosis leads to laboratory testing that shows the thrombocytopenia. And there's two different clinical scenarios that you'll see reported. In surgical patients, primarily orthopedic surgery, and the number one surgery here is knee replacement, and also in cardiac surgery patients. You'll also see this in a medical patient with infection. And here, the antibodies that are produced, again, they are produced, it's an immune phenomenon, and they bind to platelet factor 4, and they activate platelets in the absence of heparin. And what these are antibodies that bind to a combination of platelet factor 4, which is bound to another anionic substance, another polyanion. So it's not heparin, it's a polyanion. And we think that these may be due to naturally occurring polyanions such as lipopolysaccharide from bacteria, glycosaminoglycans, which could be released in orthopedic surgery, and even bacterial RNA and DNA can be polyanions that bind to platelet factor 4 and induce this formation of antibodies. Well, how do you test for this type of condition? Well, it's not particularly easy. You can use the ELISA immunoassay for IgG, and it's usually going to be positive. But this compound here that it binds to is now a polyanion platelet factor 4 combination, not heparin. Now, one way to detect this condition is to add heparin to this ELISA immunoassay. Unfortunately, that's not a standard procedure, and it's typically not done. Well, this condition will also cause a positive result in the serotonin release assay. But if you actually were thinking about this type of condition, what you want to do is get a positive result without adding the heparin to the assay. And what that shows you is that you have a heparin-independent antibody that activates platelets. Well, this type of condition is probably what you're seeing also reported in COVID-19. Of course, patients with COVID-19 are exposed to heparin. There's been multiple reports of COVID-19 patients with heparin-induced thrombocytopenia that never had exposure to heparin, however. If you look at these reports, you'll see that there are primarily positive ELISA immunoassays, although some have reported to be negative. But frequently, they don't go on to do a platelet activation functional assay in their patients, and they just report it as heparin-induced thrombocytopenia. Even in the serotonin release assay, you're going to get a positive with these patients, but they don't generally test using the serotonin release without heparin being present. And that would be the key to know that you're dealing with some other type of antibody that doesn't require heparin, but still activates platelet factor 4. Well, what is the stimulus for this assay? Well, again, in COVID-19, it may be due to the endothelial damage and release of glycosaminoglycans, but that still has not been determined. How do you manage spontaneous or autoimmune heparin-induced thrombocytopenia? Well, very similar. You want to anticoagulate because of thrombosis. You have to use an alternative anticoagulant. And theoretically, you might consider using heparin because heparin actually doesn't activate that antibody. But just to be sure, most people would suggest not using heparin, although there are some orthopedic patients that did get heparin. You also, in these patients, because the high risk of thrombosis, you want to interrupt that activation of platelets that's mediated by that FC receptor. So here you're going to use IVIG in high doses. The typical dose is 1 gram per kilogram per day for 2 days. If the patient worsens, then plasmapheresis can be considered. Well, the last thing let's talk about is vaccine-induced thrombotic thrombocytopenia. The criteria for diagnosis you may be familiar with, although as this is an evolving type of syndrome, we want to keep on top of the changes. But currently, this is kind of the diagnostic criteria that are proposed. Receipt of an adenoviral vaccine within the last 30 days, thrombocytopenia, usually it's moderate or severe, and the presence of thrombosis. And as you know, these are frequently unusual thrombosis, cerebral venous sinus or splanchnic veins, and a positive result on an platelet factor 4 heparin antibody. So an ELISA immunoassay positive. Now, this has some similar features to heparin-induced thrombocytopenia and some differences. It begins 5 to 30 days post-vaccination, with the majority within 14 days. So that's similar to heparin-induced thrombocytopenia. It's moderate to severe thrombocytopenia. But a unique feature of these patients is that there's a very high elevation of D-dimer, and more of these patients demonstrate abnormal parameters consistent with disseminated intravascular coagulation. The fibrinogen can be low or normal in these patients. So it appears to be somewhat similar to what has been called spontaneous heparin-induced thrombocytopenia. So what about tests for vaccine-induced thrombotic thrombocytopenia? So if you test with an ELISA immunoassay that we typically use for heparin-induced thrombocytopenia, it will be positive. What's interesting is the rapid immunoassays will be negative and should not be used. And the reason it's going to be positive, they've just published this in Nature. Here's the antibody where it binds in red from the vaccine-induced thrombotic thrombocytopenia patients, and it binds in this area of platelet factor 4. In this lower one, this is where the antibody for heparin-induced thrombocytopenia binds. So you can see that it binds in a similar spot, but it's a different antibody. So this assay is going to be positive. The functional assays for platelet activation will also often be positive, although the serotonin release assay has been reported to be negative in some. Once again, if you want to find out if this is a heparin-independent antibody, you have to evaluate a functional assay without the addition of heparin. Then if you actually add high dose or high or low dose heparin in this assay, it will inhibit the activation. So heparin will bind that antibody and prevent it from binding to platelet factor 4. So in the vaccine-induced thrombotic thrombocytopenia, the immune stimulus that starts this process off is not yet been identified. Potential candidates have been some combination of spike protein with other naturally occurring substances, the adenoviral sequences as well, although again, no one is sure yet. Well, I'm sure we'll learn more about this. Now, when do you treat these patients with vaccine-induced thrombotic thrombocytopenia? Well, if you have thrombocytopenia, thrombosis, and a positive ELISA immunoassay, you should treat. If you have thrombocytopenia and thrombosis and you're still waiting on a test result, you should probably go ahead and treat because your clinical suspicion is going to be high. There's also another situation where you may consider treating, and that's when you have thrombocytopenia, a positive ELISA immunoassay, and with or without a high or elevated D dimer, even when you don't have thrombosis. So again, the indications for treatment are changing, so you need to keep your kind of ear to the literature and the reports coming out. But again, I think the message here is that if you have high clinical suspicion, even in the absence of thrombosis, if you have that positive immunoassay, which looks like heparin-induced thrombocytopenia, you should go ahead and treat these patients. You'll notice that the treatment of these vaccine-induced thrombotic thrombocytopenias is very similar to what we call the spontaneous conditions. You anticoagulate, and what you'll see in the literature right now is argatroban, bivalirudin, and you'll also see a little bit more of the 10A inhibitors being used. The preferred treatment is IgG in high doses for that 2-day dose given to these patients. Whether you do plasmapheresis in addition to IgG will probably depend on if you have it available and also the condition of the patient. It is recommended to avoid heparin, even though heparin doesn't necessarily activate the platelet factor 4, and similarly avoid transfusion of platelets. Now, what about steroids? Since this is the production of an antibody, should we give an immunosuppressant drug? Well, this is still being considered. You'll see some people reporting use of steroids, but you might consider the use of steroids, particularly when you don't have access to IVIG or you don't have access to plasmapheresis. So keep in mind, and both prednisone and dexamethasone have been reported, again, only a few case reports. So I'm going to leave you again with my thoughts about how to think about these thrombotic thrombocytopenias. Again, I think keep in mind they're all immune and they all are mediated through platelet factor 4. But what we have is different stimuli. In some, we know what the stimulus is, or you could think of this as those conditions with an exogenous stimulus, and that's the heparin-induced thrombotic thrombocytopenia. I'm adding an extra T here. And we also have the vaccine-induced thrombotic thrombocytopenia, again, an exogenous stimulus. The patients, I think, in the condition that we're most likely to miss are those where we don't know the stimulus. This is the entity previously called spontaneous heparin-induced thrombocytopenia, but it's not heparin-induced. So I like the term idiopathic thrombotic thrombocytopenia. And again, I think if you're seeing a platelet count go down, you're seeing unusual thrombosis with no exposure to heparin, think about this type of condition and try to diagnose and treat appropriately. So I'll stop there. Thank you for your attention, and I'm happy to answer any questions.
afternoon, doctor. Thank you so much for your presentation. We have just a little time left, maybe for a couple of questions that arose during your presentation. One of them is when there is VITT, vaccine-induced thrombotic thrombocytopenia, plasmapheresis protocols you're familiar with, which are the doses they're using, and how is this treatment carried out?
Interestingly, there's no standardization at this point because it's such a new entity. I think many people are starting with standard doses that they might use for other conditions. But I think we'll see this kind of develop. It's also not clear how many sessions of plasmapheresis are needed. I think most are just starting with a single session of plasmapheresis. But remember, that's usually in addition to IVIG. I haven't seen anyone using plasmapheresis or reporting the use of plasmapheresis without IVIG first.
Thank you so much, doctor. There is this question also. Is there any theory stating that VITT would have this preference for sagittal sinus? Do you know why? What the reason for that is?
So I don't know why, but there are some theories that have been proposed. And one is that whatever the antigen is, whether it be part of a spike protein or a combination of spike protein and another maybe glycosaminoglycan, that this antigen actually is able to circulate into and cross the blood-brain barrier or in the endothelial, and that somehow predisposes those sites. But to be honest, it's really not known. But again, I would say that the resemblance of vaccine-induced thrombotic thrombocytopenias to what we have called spontaneous suggests that there's something endogenous that is reacting with that exogenous antigen to produce that stimulus for the antibody. And I'll also just, I failed to mention that I'm sure hopefully most of you have been vaccinated, but with the adenoviral vaccines, they have done studies in healthcare workers after vaccination, and about 8% of the healthcare workers developed antibodies that were positive in that ELISA immunoassay. So these antibodies are being produced, but they're not the antibodies that activate platelets. So again, there's a lot of factors that go into developing what we would call that pathologic antibody that activates platelet factor 4.
Thank you so much. These are very interesting phenomena. I'm sure we will get more information in time and we will have more certainty about these phenomena. Okay, doctor, thank you so much. Now we will move on to our next presentation.
Hello, hello. Good to see you, although I would prefer to be in Mexico with you. My talk here will ask the fundamental question: do we need ARDS? Do we need the letters? Do we need the syndrome? And it's a question that I like to raise because I think the answer is actually quite complex. We know that the ARDS is just a syndrome, acute respiratory distress syndrome. And it can be due to many events: sepsis in the lung or elsewhere, aspiration of gastric contents, trauma, near drowning, etc., etc. What is ARDS? Is it a form of respiratory failure with hypoxemia, bilateral chest infiltration? These are criteria. We often confuse definition and criteria. The definition is that it is acute lung edema, which is not due simply to an increase in hydrostatic pressures like in left heart failure or in hypervolemia or a combination of the two. It's important because the criteria may change. A myocardial infarction is a clot in a coronary artery. In the past, there was no reference to troponin levels, but today we would still not define myocardial infarction as something with a high troponin level. So the criteria for ARDS may change over time, and we may revisit them now that we use more high-flow nasal oxygenation. Sepsis, it's infection plus some degree of organ dysfunction. These are the criteria. But sepsis is a deleterious host response leading to organ dysfunction. And shock is a form of acute circulatory failure. You should not define shock by hypotension, oliguria, increased lactate level. So it's important to have a clear mind. You know, when we designed the so-called Berlin criteria, we had long discussions about what we would put there, and these are criteria. So it doesn't tell us very much about the cause of ARDS. And that's the reason why, even though I was part of the consensus meeting, I'm still not sure about the quality of this concept, because for clinical trials, it has not helped. Syndromes are not diseases, and survival depends on identification of the cause. So we need to individualize ARDS as much as we can. ARDS is an alteration in capillary permeability at the end, resulting in altered gas exchange, bilateral chest infiltrates of left heart failure. Do we identify it well? Well, you may remember this study conducted several years ago now with 29,000 ICU patients. And ARDS could be separate in mild, moderate, severe, but the point is that clinicians often do not recognize ARDS. And many people present this at meetings. They say, you see, you don't identify ARDS correctly. And I say, so what? What is the problem? When a resident describes a patient, and when the criteria for ARDS are there, when I say, but this patient has ARDS, the resident does like this. Oh, yeah. I say, don't worry. Doesn't matter. Because the respiratory management is the same as in other forms of respiratory failure. Oh, no, you need to protect the lungs. You need to limit tidal volumes. I know this beautiful study showing that a high tidal volume is associated with worse outcomes than a relatively normal tidal volume. That's the message of this paper. We can harm the patient when we use large tidal volumes. But now we know that this is true in the absence of ARDS as well. This is an old meta-analysis. It's now very well accepted. There have been several meta-analyses. The evidence is there to indicate that with or without ARDS, we always need to limit tidal volume. Now, even during surgery, maybe, as suggested by Dr. Futhier and collaborators here, there are more complications when you use large tidal volumes during major surgery. So always use low tidal volumes. ARDS will not change it. Of course, if the lungs are very inflamed, then the danger is even greater than if the lungs are not inflamed. But we know that we need to try to keep the lungs open with sufficient PEEP level and avoid over-distension. So it's important to try to open the alveoli, to recruit alveoli and avoid excessive ventilation of parts of the lungs. I wrote this editorial about high-frequency ventilation, and I show this because trying to use new modes of ventilation do not help very much. And high-frequency ventilation or high-frequency oscillation have not helped much. Pharmacologic management, what has worked in the ARDS? What kind of medications? We have tried many things. You could argue that maybe corticosteroids in some patients with ARDS could be helpful because there is too much inflammation. But what we need the most is an endothelial protective agent. And that's not so easy. The latest molecule we tried was interferon beta, which can increase local adenosine production. But in this study, we could not show any benefit in patients with ARDS in a larger trial. So we are left without specific pharmacological intervention. Some time ago, people would have said, you can paralyze these patients. These are old pictures of patients who were sedated and paralyzed because of the ARDS. And indeed, there was a study from Papazian showing an improved mortality, improved survival when we apply this strategy. But why would we apply it in every single ARDS patient? Why can't we individualize these decisions? So I was very pleased to see this negative trial from the NIH Tidal network showing no improvement whatsoever. So should we stop giving it? Well, maybe not. The message is not that it works or it doesn't work. The message is that it may work in some patients, but be deleterious in others. So that when we look at groups of patients, there is no improvement in survival. It means that patient management should be individualized. If you see a patient who may have excessive swings in intrathoracic pressures, then we could use muscle relaxants, but not routinely. Look at the harm that it may produce with more ICU acquired weakness, with more serious adverse events. It's not a minor decision to give muscle relaxants. So if there is silly self-inflicted lung injury from discoordination in the breathing pattern of the patient, yes, that would be an indication, but not in all patients. We need to consider the benefit risk. With paralysis, less silly, but more neuromuscular weakness. Otherwise, we learned that we should try to optimize sedation in every single patient using the early cash concept. Comfort, yes. With analgesia when needed, yes. But minimal or no sedation. Humanized care, yeah. Let's talk to the patient. Let's reassure the patient. Let's try to ambulate the patient as soon as we can. Fluid management. That's important. There is edema in the lungs, so you need to give diuretics. Ooh, yes and no. If the patient has no hemodynamic problem, yeah, maybe. Or at least we should avoid hypervolemia in all cases. But we should not forget that diuretics have an inverse effect than fluids on the Frank-Starling relationship. So we could decrease cardiac output. Decrease cardiac output, decrease oxygen delivery to the organs. That could be very harmful. Remember this now old study looking at conservative versus liberal fluid management in ARDS? Well, these patients were basically stable, so that it could indeed reduce the duration of mechanical ventilation without major harm, except that several months later, you can see that patients were in the restrictive fluid management group more often had an impaired cognitive impairment. Wow! That suggests that brain perfusion was decreased. So you may decrease the duration of mechanical ventilation, but be careful. Watch the brain, perhaps the kidneys, if there is tissue hypoperfusion. So we need first to recall the phase where we are. Is it the optimization phase or the stabilization de-escalation phase? In the stabilization de-escalation phase, we can limit fluid administration and give diuretics, but not when tissue perfusion is still compromised. Then we need fluids to maintain a sufficient cardiac output. Of course, we don't want to amplify the degree of edema. Of course, we don't want to do that. So what we need is a fluid challenge. We can look at this paper published very recently where De Backer, Ciccone, and I briefly described how to do it. How to make sure that the patient is on the Frank-Starling relationship. And basically, we give a small amount of fluid and we look at changes in cardiac output that may be associated with that bolus of fluid. If the cardiac output increases, if there is no excessive danger, then we can repeat the fluid administration. Otherwise, we stop it. We stop giving fluids. Professor Teboul may argue that we could do an internal fluid challenge with passive leg raising, but it's the same thing, except that the passive leg raising test will bring less fluids and the signal may be less significant. But you still look at the change in stroke volume and cardiac output. What is the cause of ARDS? No, what is the cause of ARDS and what is the cause of death in ARDS? Death may actually be due to the underlying cause much more than to the ARDS itself, especially now that we have ECMO available. So we could use it in a relatively young individual with potentially reversible causes. So we should not really die of ARDS. And if we look at autopsies, do we find something specific? No, really. At the end, it should be diffuse alveolar damage in all cases, regardless of the etiology. But it's not necessarily the case. Already more than 15 years ago, Dr. Esteban showed that diffuse alveolar damage is often absent at autopsy. With Dr. De Hampton, we reached the same conclusion in our department where we do autopsies on a routine basis. It's amazing. Out of 64 patients with established ARDS, 1/2 exactly had the diffuse alveolar damage pattern, and 1/2 did not. So even at autopsy, it's not a single entity. And Dr. Thiel observed the same findings. Diffuse alveolar damage in about 1/2 of the cases. I'm speaking about heterogeneity. But today we could speak about COVID-19, which is a single disease. And in COVID-19, we know all the discussions about ARDS. Well, first of all, the acute respiratory failure usually appears more than 1 week after the initiation of the viral disease. So it's no longer ARDS, but okay. The point is that CT scans do not always show the typical diffuse alveolar patterns. The compliance is not always decreased. So even in a single disease, acute respiratory failure can be somewhat heterogeneous. And that is why Professor Gattinoni and colleagues referred to type 1 respiratory failure and type 2 respiratory failure. This is open access. You can find it easily. And it shows you that COVID-19 is not a straightforward disease. And I had the chance to contribute to this Italian study of Dr. Grasselli, and we found that basically in severe ARDS, the compliance is not always reduced. So the management should be individualized. We found in our own series of autopsies that there is nothing specific in any organ. Early diffuse alveolar damage is usually present, but not always, and the viral alterations are present in all organs of the body. COVID-19 is a viral sepsis with endotheliopathy involving the lungs, involving the other organs. So, at the end, there are problems with ARDS. Acute is not always so acute. The risk factors are not really included. The PF ratio may be influenced by different FiO2 levels. It's not a constant ratio. And of course, the PEEP can influence it. There may be an influence of high flow nasal oxygenation, as I said. And some patients may have some hydrostatic alterations, and we may not identify that. And the chest x-rays are often difficult to interpret. It's not always so homogeneous. It's more significant at the left side than the right side, etc., etc. And at autopsy, only about 1/2 of the patients have the typical diffuse alveolar damage, DAD. In terms of management, there is no specificity. We should always limit tidal volume. We should always use some PEEP to avoid high FiO2 that could be harmful to the lungs. We should always consider the patient positioning. I have not mentioned that because prone positioning is reserved to the very severe cases, and we don't miss the very severe cases of ARDS. So we will not miss the patients who could benefit from prone positioning. They typically have a PF ratio below 150. And we should always avoid fluid overload. That's why the fluid challenge technique applies to every single patient. And if we diagnose, if we recognize ARDS, it does not imply anything. I must say at the end that I like to use the word or the letters ARDS. When I make rounds in your unit, I find a great heterogeneity in the patient populations, and I love it. I love it. That's why I love intensive care medicine. It's never boring. It's never the application of protocols that would be the same for every single patient. So saying that the patient has sepsis does not really change the management, except that it shows it's a severe problem. Saying that the patient has ARDS does not change the management, except to say that this is severe. But when you say that the patient has ARDS, I know what we will look at. I know what the problems will be. These problems of oxygenation, of adequate PEEP, of adequate fluid balance for looking at the source, etc., etc. So by these 4 letters, I already know quite a bit about the discussion. So ARDS may tell us that the situation is severe, and that we need to find a cause. If it's not COVID, where it's straightforward. If it's something in the abdomen, something else, I don't know what, I will look for it. But the risk, and that's in red on the graph here, is that I have identified ARDS, and now I will try to find the best PEEP, and I forgot about the cause, because I will think that ARDS is a disease. That would be very, very bad. ARDS is not a disease. We need to personalize our strategies, and that's a recurrent theme in critical care medicine today. So we need to identify phenotypes, and Dr. Calfee and others have helped to show that, for instance, if you consider a statin administration, there are some patients who may benefit and some patients who may actually be harmed, because statin has anti-inflammatory effect. So if there is a strong hyper-inflammatory response, then statins may be indicated. If it's not the case, we should not give it. So that's important. We should not find a treatment for all ARDS patients. The same is true for fluid administration, though here actually they reverted the two groups, and they found that Group A was Group B and Group B was Group A. So it's not so easy. It's not an easy approach, but we are getting there, trying to find simple variables that could help to orient our therapies. And that's really the way to go. Is it a hypo-inflammatory phenotype or a hyper-inflammatory phenotype? Corticosteroids, other anti-inflammatory strategies, that's for the hyper-inflammatory type. So we need to better identify the right patient for the right treatment. And that's really the future of ICU treatments. As we wrote with Dr. Slutsky and Gattinoni, we can really personalize our therapies. And that's the reason why recently Dr. Slutsky and I say that we have never seen a patient with ARDS. Of course, it's provocative. It's because we have seen patients with many underlying diseases that could lead to ARDS, but ARDS only. We never see ARDS only. It could be COVID, it could be something else. ARDS is superimposed to a given disease. Muchas gracias. Thank you.
Thank you very much for the invitation to speak. My name is Eddy Fan. I'm an intensivist from the University of Toronto. And today I'm going to be talking about ECMO for severe COVID-19. Here are my disclosures. I won't be speaking about any specific products in my presentation today. So I think the starting point for a discussion about the utility of ECMO for COVID-19 is really to frame our understanding of what severe COVID-19 represents and what evidence or data we have to support the use of ECMO in COVID-19. And really the story begins with the idea that ARDS is a syndrome and COVID-19 is now a new cause of severe ARDS. As many of you know, ARDS is, again, a syndrome that was first described in 1967 by Ashbaugh Petty, pulmonologists in Colorado, who really, you could see on the right, described the clinical features and potential therapies that are still germane today in 2021. We see patients with severe hypoxemic respiratory failure characterized by the acute onset of tachypnea. Again, they have very severe hypoxemia often. There's a loss of respiratory system compliance. And of course, these investigators coined the term because they saw histopathologically that it resembled respiratory distress of the newborn. And even then, they described the potential therapies that we're still using today, positive pressure ventilation and PEEP, which are really the cornerstones of the management of patients with ARDS, and still controversy around the routine use of steroids. Although again, in the COVID-19 pandemic, we've seen a resurgence of data suggesting the utility of steroids in COVID-19 associated ARDS, and perhaps more work to follow on the use of steroids in ARDS from other causes. In 2021, we have a slightly newer definition that's built on the work from Ashbaugh, Petty, and Forward in Time. It's the Berlin definition. And again, the same 4 criteria that were present in the 1994 American European Consensus Conference definition, with just some refinements on the timing, the nature of the chest imaging, the origin of edema, and oxygenation. But again, really the biggest sort of evolutionary change in this definition was the characterization of oxygenation or hypoxemia into mutually exclusive categories of mild, moderate, or severe. And you could see along the bottom row that patients with mild ARDS have a PF ratio of 200 to 300. Those with moderate ARDS have a PF ratio of 100 to 200. And the severe patients, which we're going to focus on today, are those with a PF ratio less than 100. And importantly, we want to link predictive mortality to the severity of disease. And you can see here on the bottom that in mild disease, mortality was as low as 27% and rising to as high as nearly 50% in those with severe ARDS. And again, today we're talking about the idea of linking the intensity of therapeutic interventions to the severity of the underlying disease. And today we're focusing on ECMO, which, as you know, is a relatively invasive, resource-intensive intervention that has its own share of complications. And so you don't want to be deploying risky interventions in patients with relatively low chances of dying or having bad outcomes. You really want to use these interventions in patients at the highest risk of bad outcomes, where the risk-benefit ratio for that intervention could actually lead to benefit for the patients. And so again, for the treatment of ARDS, of whatever etiology, we recently had multi-professional society guidelines looking at what could be used. And just to say that ECMO, of course, as this intervention really comes at the tail end of a gamut of evidence-based therapies that include things like low tidal volume ventilation, perhaps a trial of higher PEEP, perhaps a trial of deep sedation and neuromuscular blockade, in the absence of contraindications, a trial of prone positioning, and in patients who still remain quite hypoxemic or have refractory respiratory acidosis due to hypercapnia, you could consider VV ECMO in those cases. And so when we think about COVID-19, which is the pandemic that's been ravaging the world for the last year or so, there was quite a bit of controversy then in whether or not COVID-19 was really leading to a new type of respiratory failure, or really if it was just ARDS in general. And this is important because if COVID-19 was spawning a new manifestation of hypoxemic respiratory failure, there were calls that perhaps we should change the way we approach the management of COVID-19 associated pneumonia or severe COVID-19. And again, early in the pandemic, you had lots of thought leaders and opinion leaders writing things like Luciano Gattinoni, whether COVID-19 pneumonia is ARDS or not. But certainly as the pandemic has evolved and we've gleaned more data from jurisdictions around the world, we're starting to see reports such as this one from the Spanish ICU network confirming that on the whole, COVID-19 pneumonia or severe COVID-19 really results in ARDS. And again, this idea that whether there are phenotypes, and if there are different phenotypes, different treatments that are required for this sort of clinical syndrome, this popular idea early in the pandemic about differences between a type L phenotype and a type H phenotype, and maybe a transition between these two as time goes on. But really, as we've developed more and more data from, again, cohorts around the world, we see that when we look at things like PF ratio, respiratory system compliance, how these patients are ventilated, and so forth, they actually represent what we understand about the heterogeneity of ARDS, and really are quite consistent with what we see in other large cohorts of ARDS patients caused by non-COVID-19. And again, perhaps the best example of that is looking retrospectively at the LungSafe data, which looked at ARDS in 500 ICUs in 50 countries around the world. You see again that average PF ratio, plateau pressures, ventilatory parameters, and so forth are very consistent with that reported in patients with COVID-19, suggesting again that COVID-19 really is just a new cause of ARDS. There was a lot of talk at the beginning of the pandemic about cytokine storm. And indeed, now looking at the data, this very nice study from Dan Leesman showing that, in fact, there are many other conditions in the ICU that actually lead to much higher levels of cytokine elevation and inflammation than severe COVID-19. So this idea that cytokine elevation or cytokine storm in COVID-19 is also somewhat reduced. And finally, postmortem examination and histopathological findings as time has gone on has really shown that these patients have pretty clear links to what we see histopathologically in ARDS. There's diffuse alveolar damage, and diffuse alveolar damage includes pulmonary hemorrhages, microthrombi, and these sorts of things. So really seems to be consistent with ARDS. So finally, looking at the UK and Iran appropriateness panel, basically concluding in the end that the management strategies in mechanically ventilated patients with confirmed or suspected ARDS, they pretty much mirror those that we would consider in our evidence base for the management of patients with non-COVID ARDS. So as the pandemic has evolved, the important thing is that something there where there were many unknowns and many hypotheses, we've gathered data and experience, which has now led us to the conclusion that COVID-19 or severe COVID-19 leads typically to ARDS in the vast majority of cases. And therefore, our approach to the management of patients with severe COVID-19 should mirror that of the evidence-based management of patients with ARDS. The expert panel here found no reason to deviate from the evidence-based supportive strategies for managing ARDS in current guidelines. And therefore, in the most recent iteration of the Surviving Sepsis Campaign guidelines for the management of COVID-19 really is a translation of our current evidence-based therapies for ARDS. It's really been incorporated into the Surviving Sepsis Campaign guidelines. So then ECMO. So where does ECMO fit for COVID-19 ARDS? Well, as again, we've set the stage, it fits in the same way that VV ECMO is used or considered for patients with severe ARDS of other etiologies. And interestingly, our knowledge in the adult world on the utility of ARDS of ECMO for severe ARDS really grew from another pandemic. So in the days of the H1N1 pandemic that gripped the world, we saw quite a few young, previously healthy patients presenting with severe ARDS and very refractory, life-threatening hypoxemia. And that really started this early rise in the use of ECMO again in adults, and then eventually outstripping its use in neonatal and pediatric populations to rescue these patients who were dying of refractory hypoxemia. And research following on the H1N1 pandemic led to a resurgence in its use in adult patients. And of course, now in 2021, we have an increasing amount of data supporting the use of VV ECMO in patients with severe ARDS. On the left, you have the landmark trial, the EOLIA trial led by Alain Combe and colleagues. We were fortunate to have been a study site for this trial in Toronto, but really an international randomized controlled trial with 60-day mortality as the primary outcome. The trial was stopped early after randomizing 249 patients because the result didn't quite reach statistical significance. So despite an 11% absolute risk reduction in 60-day mortality in favor of the ECMO group, it didn't quite reach statistical significance. However, following the results of this trial, a number of secondary analyses now increase our confidence that VV ECMO is useful in this population, including a Bayesian reanalysis led by my colleague here in Toronto, Ewan Goligher, suggesting a very high probability of benefit for VV ECMO in patients with severe ARDS, to meta-analyses, including a study-level meta-analysis and an individual patient data meta-analysis, again, supporting the use of ECMO in severe ARDS, and finally, a network meta-analysis that shows that when comparing to other therapeutic interventions, such as prone positioning, higher PEEP, neuromuscular blockade, that again, VV ECMO is useful in patients with severe ARDS. So really, again, highlighting the fact that ECMO in patients who have had a run at evidence-based management, including low tidal volume ventilation, perhaps neuromuscular blockade and higher PEEP, and prone positioning in the absence of contraindications. If these patients continue to meet the inclusion criteria for EOLIA and they have no contraindications, these are the kinds of patients that we should be considering for ECMO. And certainly in the throes of the COVID-19 pandemic, jurisdictions that around the world saw a vast deluge of patients with very severe hypoxemic respiratory failure from COVID-19, and many of which could meet these criteria. Unfortunately, early in the pandemic, again, partly due to, again, the immense numbers of patients overwhelming many health systems around the world, ECMO perhaps was being used as a salvage therapy really at the end stages of multi-organ failure. And in that situation, we really wouldn't expect ECMO to be useful. In this very early pooled analysis of very early reports, many of them from China and Wuhan, where the virus really took its first hold and infected a very large number of patients. What you can see here, unfortunately, is that ECMO use in these handful of patients here really led to dismal survival. Most of these case series or case reports reporting 0 survivors. And again, really, you have to take this data in context, because many patients, again, many health systems, hospitals were overwhelmed at this point. ECMO was being deployed perhaps later and later, where its ability to rescue patients was probably questionable. And even the results of these reports led to calls for a moratorium on ECMO use in patients with severe COVID-19, and also fueled perhaps with the idea that COVID-19 was somehow different than severe ARDS, and perhaps so therefore its response to ECMO could be different. However, again, as the pandemic went on and adhering to sort of our evidence around the use of ECMO in patients with severe ARDS, sort of following the inclusion criteria set out by trials like CSER and EOLIA, we started to see that you could get results that were in keeping with our previous experience on the use of VV ECMO in patients with severe ARDS. So here are data from Mathieu Schmidt and colleagues from La Pitié Hospital in Paris, show a very high volume ECMO center in France, showing that indeed, when you adhere to sort of the evidence-based criteria for the deployment of VV ECMO in patients with severe COVID-19, you could get results that were very similar to that from randomized control trials and from international cohort studies of the utility of ECMO and VV ECMO in ARDS. So really here, having a mortality more in the 30-35% range, which again, consistent with previous reports, and in an international look at data from the Extracorporeal Life Support Organization led by Ryan Barbaro, similarly, you could see that in over 1,000 patients receiving VV ECMO for severe COVID-19, the mortality rate just under 40%, again, more consistent with previous reports on the mortality rate in severe ARDS patients being supported with ECMO. Interestingly, there are a number of important factors that might modify the effect of ECMO in these patients. And again, these are data from a ECMO network in the greater Paris area, showing that important factors include the experience of the center. So again, there's a clear volume outcome relationship between the use of ECMO and outcomes. Centers doing 30 or less cases in the previous year versus higher volume centers doing 30 or more cases, there's a clear separation in mortality. Those who were transferred or not, there didn't seem to be a significant difference. But again, perhaps not surprisingly, older patients had worse outcomes, and patients who were initiated on ECMO later, so using less than 3 days between intubation and ECMO as compared to 3 to 6 days or greater than 6 days, you can see that the earlier the ECMO was implanted, the lower the mortality. And again, in a multivariable model, additional factors, including those, the existence of renal failure and case volume and time to intubation, along with age, were significant factors in the modifying the effect of ECMO in these patients. And finally, we now see that when as the pandemic has evolved and as centers have become more comfortable with managing these patients, deploying ECMO using the evidence-based indications, there have been quite a few now, mostly either retrospective or small prospective studies, apart from this larger study, again, from the ELSO registry. We see that mostly these are single center or few center studies, but the pooled mortality across most of these published literature on the use of ECMO in COVID-19 represents a mortality under 40%, which again is relatively consistent with that which has been seen for the mortality rate of ECMO for severe ARDS before COVID-19. Interestingly, when you look at meta-regression to identify covariates which may be significantly associated with the risk of death, again, the idea that ECMO duration and age seem to be significantly associated and consistent with previous studies, both in ARDS and in COVID-19, a higher BMI actually appeared to be protective. What about those who, despite all our conventional measures and including ECMO, sort of fail to separate from life support or unfortunately seem stuck in our intensive care units? And again, as jurisdictions around the world now are seeing more and more this idea of persistent or long COVID, and even those who leave the ICU, many of these patients unfortunately now are developing persistent lung injury or the sequelae of severe lung injury, including pulmonary fibrosis, and almost appearing like chronic lung disease patients with poor pulmonary function and as a result, poor health-related quality of life. And now the question of lung transplantation in these patients has also become, has been brought up. So my colleagues here in Toronto, Marcelo Saipel and Shaf Kashabji, who lead our lung transplant program, they're thoracic surgeons, wrote a very nice and provocative idea in a piece in Lancet Respiratory Medicine outlining who might we consider lung transplantation for in these patients who are either stuck or managed to leave and get discharged from the ICU or hospital, but now have evolved into more chronic lung disease patients. And again, these are probably not very counterintuitive when you think about them. These would be patients who are younger, less than age 65, they have single organ failure. Importantly, they've had sufficient time to allow for the chance for lung recovery. I think something that we've been learning in the ECMO space, even before COVID-19, is that the lung actually has a pretty reasonable chance to regenerate, heal, and recover if given sufficient time. And longer run ECMO has definitely demonstrated this possibility in some patients. So we want to ensure that we're not pulling the trigger too early and allowing sufficient time for a chance for lung recovery. Amongst those who don't have lung recovery, there should be some radiological evidence of irreversible lung injury or damage, including severe bullous destruction, established pulmonary fibrosis. The patient should be awake and able to discuss the decision for transplantation because it's a lifelong commitment. They should be able to participate in physical therapy while awaiting transplantation. They should otherwise fulfill the remaining typical criteria for transplantation in terms of BMI cutoffs, lack of other significant comorbidities. Again, they hopefully are COVID recovered with a negative SARS-CoV-2 PCR. And again, here we're talking about something that we're currently is being investigated and reported on in centers around the world, but embarking on the transplantation of patients with COVID recovery, lung injury, and maybe supported with ECMO. These should be done in centers with substantial experience with high-risk lung transplantation. And again, from an ethical and logistical point of view, this should be done in places where there's a broad donor pool and low waiting list mortality to avoid competition, if you will, with those patients with other chronic lung diseases who are currently waiting for lung transplantation in those jurisdictions. And we started to see these reports, including this one from Vienna, showing the transplantation of patients who had recovered from COVID and very prolonged, as you can see here, up to day 58 ECMO that included both VV and VA ECMO, resulting in bilateral lung transplantation. And unfortunately, in many of these case reports, these patients actually, despite the very long ICU and ECMO runs, managed to survive lung transplantation and eventually convalesce and be discharged not only from the ICU, but from the hospital. And this report recently published in the Lancet Respiratory Medicine from 6 large and experienced lung transplant centers around the world, describing their experience, their combined experience with 12 patients with COVID, severe COVID-19 that actually underwent lung transplantation. You could see that many of them had very prolonged course on ECMO as a bridge to lung transplantation, some approaching over 100 days. Many of them were awake and again, able to do some physical therapy and mobility during bridging. Many of them again had CT findings that suggested irreversible lung injury. And importantly, all of them had a pretty reasonable short-term mortality, able to leave the hospital and be discharged from the ICU and separated from ECMO, but very comparable short-term mortality to similar patients without COVID-19 who underwent lung transplantation. This is a very nice sort of summary of the amount of time spent in each phase, if you will. And you could see that, again, these patients had experienced a very long duration of critical illness, nearly 80 days from the onset of their symptoms to lung transplant listing, and then a subsequent wait for lung transplantation. But again, overall, all patients were able to be weaned from ECMO and leave the intensive care unit and had very similar short-term survival to transplant recipients without COVID-19. So something that I think many jurisdictions in the world are now considering, waiting to hear the experience and data from these experience centers to understand better how to prioritize or consider candidates for lung transplantation following COVID-19, but more data is on the way. And then finally, maybe just as a provocative idea, in terms of getting these patients to a state where you can maximize the chances of either recovery or candidacy for ECMO, for lung transplantation, is this very nice case report from, again, Mathieu Schmidt and colleagues in Paris, showing a patient that with COVID-19 that they supported without invasive mechanical ventilation. So in this patient who arrived with COVID-19 and was admitted to the intensive care unit on high flow nasal oxygen and non-invasive ventilation, they managed to put this patient on early to VV ECMO to support gas exchange and maintain this patient throughout their stay with ECMO and a combination of high flow nasal oxygen and non-invasive ventilation, and managed to bridge this person to recovery without the need for invasive mechanical ventilation. So again, as we're thinking more and more about the optimal strategy of getting these patients to a state where they can either recover, or if they fail to recover adequately, where they could be the best candidates potentially for lung transplantation, a strategy that favors the awake, cooperative, mobile ICU patient without the need for invasive mechanical ventilation, this would be a very attractive strategy to consider in the right patient. Of course, this is a single case report and it's hypothesis generating. This is in no way high quality data. This is just a paradigm shift at the moment in how we treat these patients, but really just to highlight what could be possible in a certain group of patients as we move forward. So to conclude, I hope I've shown you that critically ill COVID patients develop what we think is typical ARDS. We know that ARDS is heterogeneous, so there's going to be a spectrum of their presentation that is apparent, and COVID-19 seems to fit in that. And again, as the pandemic has evolved, we have now increasing evidence that it resembles typical ARDS in most cases. So therefore, we should provide the best evidence-based management of these patients with ARDS as we've known from the past. We should consider VV ECMO if there's refractory hypoxemia or there's refractory hypercapnia with injurious mechanical ventilation. Data now suggests that things like early deployment, younger age, and fewer comorbidities may be important factors that modulate the response to ECMO or their association with outcomes in patients who are going to be supported with ECMO. There could be a potential role for lung transplantation, particularly in those that develop chronic lung disease and meet traditional transplant eligibility, but more data is forthcoming, and very important to align these discussions with legal, ethical, and logistical considerations in the jurisdictions that are considering a move to lung transplantation for these patients. And finally, just a call for all of us to remain humble in the face of a new entity. When COVID-19 spread across the world initially, we had very little data, lots of hypotheses, but very little data, which is not a problem, because the point is that until we get data, we can have our conjectures, but then modify our thinking as the data evolves and changes the way that we think about things. So maybe famously or apocryphally said by Winston Churchill, when the facts change, I change my mind. So as new data comes from the pandemic, we need to change the way that we think to align with the best data and the experience from our colleagues around the world. So with that, I want to thank you very much for your attention and appreciate again the invitation to speak today. Thank you very much.
Hello, I'm John Marini from the University of Minnesota. I'm a professor of medicine here in Minneapolis and St. Paul. I'll be talking about the question of whether we should modify our traditional ventilatory strategies for ARDS. I have no financial relationships and conflicts of interest for this presentation. Now, as someone who is fairly advanced in my career, I have seen many changes over the years, and I think we started with the orientation that we should be clinical physiologists, and we have evolved into the idea that our scientific information should be coming from the clinical statistician. As you might guess, I am not very happy about that transition. You might ask the question, did the steamroller of statistical research pave the road to the Oz of outcomes, like in the Wizard of Oz? Or did it lead us in a dangerous direction and push us off a cliff? And a little bit of both is the truth, but I'll be concentrating on the second. Our standardized approach to ARDS has become this. We use low tidal volumes, we use high PEEP, at least in the early phase of ARDS, to address oxygenation problems, and we use upright positioning whenever possible. Should we change our standard approach? Well, there are reasons to think yes and reasons to think no. And COVID-19 has shown us that we sometimes make big mistakes when we adhere to our standard approach. Why should we change the way we do things? For COVID-19 ARDS and for other types of ARDS too, we have to consider this. There are novel characteristics of COVID-19 ARDS, which I'll call CARDS, C-A-R-D-S. I'll be talking about newer concepts in ventilator-induced lung injury and about managing CARDS in specific. Now, one of the unusual features of the coronavirus is that it affects the vascular side to an extreme degree. This is not typical ARDS, no matter what people tell you it is, based on an X-ray or an oxygenation criterion. It is pathologically different. And we've seen that over the last year and a half in various publications. This is a nice one, emphasizing that there's an endothelitis, thrombosis, angiogenesis, and actually dysregulation of the ventilation perfusion matching. We see even early on changes that suggest that air spaces may be expanded, not necessarily contracted or atelectatic. And there is evidence for occlusion of vessels, at least in autopsy information, that exemplifies the problems that we have with clotting and with the endothelium. Severe CARDS, unresolving CARDS, encourages fibrogenesis. And this has been emphasized quite a while ago now by an Italian group from Genoa. Lung fibrosis was seen in many of their patients that were coming to autopsy to an extensive degree. And I will emphasize that a little later when I talk to you about the mechanics of these patients. Now, very early on, actually about a year ago, the Wall Street Journal interviewed me and some other individuals regarding our dispute about how to manage CARDS with respect to the ventilator. That dispute has continued. The stimulus for the heated controversy is this paper from Luciano and his colleagues indicating that COVID-19 pneumonia has different phenotypes. In other words, when the patient comes to the hospital, they may look either one way or another, and these two presentations are actually emblematic of the time at which the patient arrives at the hospital more than anything else. In one case, you have a flexible lung. In another case, you have a very stiff lung. And I'll talk more about that. He called the first type the L type, which is earlier and milder and characterized by different types of infiltrate, than the H type, which was later, more severe, and more characteristic of the radiographic appearance that we normally see with ARDS. Now, how do I define ARDS? Well, it's based on bilateral infiltrates and a PaO2 to FiO2 ratio that's low. And in both cases here, you have a similar PaO2 to FiO2 ratio. In both cases, you have infiltrates, but there's a problem because they're very different in their mechanical characteristics. This first one, this L type, is gas-filled, even though the patient is hypoxemic, reflecting the vascular component in dysregulation. Later, there is better matching between ventilation and perfusion and more resemblance to ARDS of the conventional type. The important thing is that these cases are not all uniform and they should be managed differently. Now, some very smart people have suggested that there really isn't any difference in compliance for early and late COVID-19 ARDS versus what we normally see with ARDS. And this is absolutely wrong. They have ignored a number of things in this presentation. They haven't considered the timing of observation or the technique of compliance measurement. After all, if you have a gas-filled lung and you puff it up with a lot of PEEP, you're going to see a low compliance, even though the innate tissue is actually quite flexible. And early on, the lung is much more flexible than it is later. Even in data that have been published from groups that have not agreed with us, you see that the compliance range is dramatic in these patients. And this is not typical for ARDS of the usual type that we normally see. In fact, compliance evolves and standard type of ARDS properties emerge. There is, in fact, an L to H transition over the course of disease. So if you find someone who is presenting after symptom onset quite late, you will find a compliance that's quite low. If you catch them early, even though they're hypoxemic and come to the hospital, they may be without any symptoms of even dyspnea, the happy hypoxemics, as we call them. Early on, there's a CT ground glass and crazy paving pattern. It qualifies as Berlin ARDS, but is it really typical ARDS? And the answer is no. The distributions of tissue and gas in ARDS versus CARDS are quite different. With, as I mentioned, the gas volume is not only more plentiful in CARDS in the early stages, but it's distributed evenly from non-dependent to dependent areas. We put those ideas into motion in this paper in intensive care medicine, where we compared ARDS matched with the P to F ratio and ARDS matched on compliance ratio with CARDS, and we found that the venous admixture in CARDS really was not related to the tissue fraction that was consolidated, whereas it was in both other types of ARDS. The mechanisms are different. That is the key point. So given those atypical features, should COVID ventilatory management follow the usual guidelines? Many of us have heard this quote before, but it's worth pointing out. The whole problem with the world is that fools and fanatics are always so certain of themselves, and wiser people so full of doubt. And I hope I'm one of the latter, because I don't think we should adhere to the specifics of what we've learned to do in ARDS. Now, there have been a number of authors who have taken delight in trying to cram a square peg into a round hole, and basically emphasizing that CARDS is just ARDS and should be treated similarly. And the standardized approach to ARDS is 3 sacred cows: low tidal volumes, high PEEP early on, and upright positioning. What about high PEEP? Let's start with that sacred cow. The familiar effects of PEEP are to reopen a vascular bed, improve oxygenation, and if you're lucky, have less hypercapnia. If you do not open the vascular bed and the recruitable tissue, if you do not have recruitable tissue, to work with, you simply increase PVR, the pulmonary vascular resistance, and may deteriorate gas exchange and increase the risk of lung injury. In early COVID-19, this expansion of recruitable lung units does occur, but it's not very effective. It's a reopened vascular bed, and it does not have, unfortunately, better gas exchange. It has an increased dead space, a redirected blood flow, and you may not find much response in terms of oxygenation. You'll see some, but not a big response. So again, it's the vascular kinetics that are very important here. There is a paper out there, a very good paper by very good people, saying that basically they're broadly similar between COVID-19 ARDS and regular ARDS, and we recommend adherence to evidence-based management. What do you mean by evidence? If it's randomized clinical trials and statistical evaluations of populations applied to the patient, I think that's probably not the right thing to do. For example, this is the ARDSNet table for PEEP. Even lower PEEP and higher FiO2 management zone, you see that the PEEP levels are actually quite high. 14, 16, 18, even 24 centimeters of water. And against the background of the abnormal mechanics that I just mentioned, that may be a dangerous strategy. I try to put these ideas along with Phil Dellinger and Daniel Brody into this scenario of an evolving problem that goes from better lung compliance, ineffective recruitment. Remember, I told you, you do recruit, but it's not effective. An atypical PEEP response, ventilation perfusion mismatching, gas-filled lungs, ground glass infiltrates, adequate organ function, limited inflammation, and some have even suggested immune suppression. That progresses over time to very bad lung compliance, usual PEEP and prone responses in the middle zone of the transition period, extensive shunting, edematous lungs, consolidating infiltrates, etc. So again, why is there disagreement regarding compliance? Earlier, COVID lungs are relatively compliant but oxygenate poorly. Higher PEEP levels geared to oxygenation overdistends the tissue and also causes low compliance to be measured. Later, there's fibrotic contraction and a low compliance. Impaired mechanics catch up to the impaired oxygenation. There are other controversies. Is P-SILI, patient self-induced lung injury, relevant to CARDS? Should we delay intubation or go early? And we've learned as the disease has progressed in our experience that we should try to avoid intubation, but if a patient is not improving or is beginning to deteriorate, we should not hesitate. What about upright positioning? This is a very interesting one that most people would say, come on, everybody should be positioned upright. But this is another sacred cow in this disease, especially. There are unfamiliar mechanics in some late stage. Now we're talking about the very late stage of severe CARDS. And this is from a paper that is published this month that I contributed to. 7 patients here who are managed with certainly what should be considered lung protective tidal volumes, relatively low PEEP values. But notice that, first of all, the driving pressure is in these patients is relatively high. The plateau pressures are relatively high. The compliance is very low. But these 3 highlighted patients, patients 2, 4, and 6, demonstrate that when you reduce PEEP, even from a level of 8 to 5, the compliance improves in this one, from 10 to 5, from 21 to 42 in this one. And basically the message is that we don't think that these levels of PEEP are overdistending the lung, but they apparently are, even with lung protective tidal volumes. And I'll try to get to the answer of why we think that's happening in just a second. Again, these are very low compliance, late stage patients. In fact, we discovered that stiffening the chest wall and reducing the baseline volume sometimes helps lung protection. We did it by what we call a belly push. In other words, press firmly on the abdomen, drive the diaphragm a little higher, retract the volume. Others, Macan Sodesep and colleagues in France, put heavy weights on the sternum and found something similar. Both papers were published within the last 6 weeks, by the way. I think ours was first, but theirs followed quite quickly afterward. This is an example of what you might see. Okay, here is, you're talking about constant flow of ventilation, and you see this basically biphasic curve, even though you're using small tidal volumes, and you're seeing high plateau pressures, in this case 40. Now, after you regain the tidal strategy and start the belly push procedure, you actually improve the mechanics of the chest. The plateau pressure, even though you have reduced the overall lung volume, has gone from 40 to 28 in this instance. And when you remove the weight, now this is steady pressure, by the way. This is not episodic inspiratory pressure or episodic expiratory pressure. This is steady pressure, steady weight on the chest. You see a recovery again of the pattern before weight was put on. This is the pattern of compliance that we saw, plateau pressures that we saw, and these are the 3 patients that we reduced PEEP in. During compression, we had beneficial effects, and this is written about in chest, as I mentioned. Here's an example of what you see at the bedside. You notice there's a slightly upward tilt of the stress index, if you want to call it that, the positive stress index, and you have a high plateau pressure going to a much lower plateau pressure during the belly push, even though the tidal volume is essentially the same. And the reason for that, may be all mystifying to you as it was initially to us, is that the chest wall, when you press on it, it changes its compliance characteristics, mainly by shifting rightward on the pressure-volume relationship. The lung, however, doesn't change its characteristics as you push on it. And what does change is that your tidal volume is moving between these 2 blue points here to these 2 black triangles here. You're at a lower lung volume, but you have better tidal compliance. And Luciano and I have written about this, and we have a paper pending at the current time. Now, I'd just like to switch modes here and talk about determinants of villi risk. I've written with that, with Luciano and Patricia Rocco about that, and involving the concept of power being central to the damage, along with high stress cycles. And that's a very important factor. A high stress cycle, repeated often enough, gives you high power that's damaging. Unlike pressure, like driving pressure, for example, the shrinking baby lung concentrates power. In other words, as you get worse and worse in the disease course, the aerated lung volume becomes smaller and the power concentrates on what's left. So there's a progressive tendency to enter an accelerating failure we call the villi vortex, where you have intolerable strains, progressive stress loading, increased ventilation load per remaining fiber, and an increase in specific power. And in COVID-19 ARDS, it's even worse because you have a vascular component to deal with. I don't have time to go into it in detail, but I do want to mention that vigorous breathing increases the transpulmonary pressure, increases the blood flow through the lung and violates all the objectives of lung protection. This villi vortex is a real phenomenon. We see sudden deteriorations in many of these patients when they enter this vortex. The reasons not to allow strong spontaneous breathing, therefore, are multiple. You will improve oxygenation generally, reduce oxygen demand in FiO2, reduce villi risk, and there have been other suggestions, prominent among them, reduce diaphragmatic dysfunction and avoid fatigue. Over time, the risks increase because of the shrinking baby lung. Now, okay, we've talked about high PEEP and upright positioning being two sacred cows that are not quite so sacred. How about the real one that we need to concern ourselves with is tidal volume? Our standardized approach to ARDS has this as a central sacred cow. In a recent paper, Goligher and Brochard and colleagues demonstrate that patients with lower compliance benefit most from low tidal volumes, and over a wide range, there's a tidal volume tolerance in those subgroups that have better elastance. It doesn't much matter whether you're using a high tidal volume or a low tidal volume strategy. In fact, if you compared mild to moderate ARDS patients in terms of compliance of 35, still ARDS, of course, but here's what they found about driving pressure. Driving pressure actually reduces the survivability if you push to very low tidal volumes. And it's only in those patients who have very low compliances, such as the ones I showed you earlier with the CARDS patients and the unusual chest wall behavior and mechanics, that they improve their odds ratio by dropping driving pressure. So the COVID phenotype progression has various stages. They should be treated different ways at different points. And again, I don't have a lot of time, so I'll just point out that we want to avoid unnecessary intubation, but intubate as soon as the patient begins to deteriorate. We've put all these concepts together, most of them anyway, more than a year ago now. In JAMA, we've gotten a lot of concern that we're not dealing with a different problem and it should be treated with standard approaches. We disagree with that. We continue to disagree with that, and there's nothing that we wrote in this paper that I currently disagree with anymore, and I know that Luciano feels the same. Again, in summary, you have an evolving pattern. Oxygenation may not look a lot different in the early stage and the end stage, but there sure is a difference between the recruitability, the consolidation, the response to PEEP, the compliance. All of these things change over time. Takeaway points for COVID-19: prevent vigorous breathing and high transpulmonary pressures, avoid high PEEP in the early phase and in the very late phase when you do not have recruitable tissue and you just overdistend what is already overdistended. Perhaps I didn't emphasize enough that when we saw those paradoxical responses, it is because we have end inspiratory overinflation. There are very few aerated lung units to take the entire tidal volume, even if it's 6 or 5 ml per kilogram tidal volume. It doesn't gas trap at the end of expiration, but it does cause overdistension at the end of inspiration. So we want to avoid high PEEP in the early phase. We want to monitor mechanics and ventilation efficiency. Important point is to personalize the ventilation, follow the plateau, the minute ventilation, PaCO2, change position, use the belly push if it's a good diagnostic procedure for you. And know that this is a problem that is not going to resolve itself quickly in most patients. The overarching lessons we've learned for CARDS and for ARDS is that lung disease is mechanically complex. Heterogeneity complicates decisions, and numerical dictates of tidal volumes and recruitability and plateau pressures, etc., are all flawed. You need to individualize and compromise. And we do know that high stress ventilation can damage the lung, particularly when it's applied at a high frequency to increase the power. Population statistics give us incomplete guidance, and physiological understanding remains the key. Should we change our approach? Yes, there is no standard approach to ARDS, in my opinion, and no guide decisions by bedside physiology. The principles are the ones that are important. You don't want to overstretch, but you have to personalize in order to get to your objective. So with that, I'd like to say gracias and thank you for my invitation to the course. And I appreciate very much my Mexican friends, especially Guillermo Dominguez and Juan Asia, who are really exemplary clinicians and great role models for younger people. Thank you.
Hello, hello. Good to be with you and to discuss this very important topic of the interpretation of mixed venous oxygen saturation, the hemoglobin oxygen saturation in the venous blood. It's basically the relation between oxygen consumption and oxygen delivery. It's really where life is. If we want to live, we need oxygen. If we want to live well, we need money. And we will see that there is a relation between the two. But oxygen delivery or oxygen transport is determined by the arterial oxygen saturation and therefore the PaO2 and the hemoglobin concentration. That's the amount of coal that we could have in the wagon of the train, but the train must have a sufficient speed to bring enough coal to the factory. So oxygen transport is easy to understand. And then the cells consume what they need. And then they will leave oxygen at the venous side of the vasculature. Or the factory will leave some coal on the wagon. And it's important to see how much is left there because it is a reserve. It's a word I will use several times, a reserve. You need to have some reserve. So you extract oxygen, which is consumption as related to delivery, and you leave some oxygen in the veins. So oxygen consumption is not necessarily equal to demand. If we are very poor and if we are in the street, we may no longer have sufficient amount of money to live properly. We need to depend on others. But the relation between delivery and consumption is the SVO2. And the relation between oxygen delivery and demand is lactate levels. So it's different. Don't put them together. These are successive steps. You first lack some money, SVO2 is low. And then when you are really out of your home, when you are homeless, your lactate levels are high. So I like the comparison with income for delivery. The amount of money we receive, let's say over a month, and consumption, how much money you put in your house, in your clothes, etc. That's your expenses. And oxygen demand is your needs. So when we dissect oxygen consumption, it depends on the cardiac output and the difference in content between the arterial side and the venous side of the vasculature, right? So the only variable that we need to include is SVO2. Isn't it wonderful? This simple, small variable will tell you the relationship between your consumption and your delivery. And oxygen extraction, if we look at the equation, does not depend on hemoglobin concentration by itself. It may be influenced by anemia, but you don't need to know the hemoglobin concentration to know the SVO2. And SVO2 is, of course, immediately influenced by SaO2. If there is hypoxemia, there is a low SVO2. But we should always correct hypoxemia. You know, some people sometimes say, what about permissive hypoxemia? No, forget about this. It's very hard for the patient, for the heart, for the metabolic response. It's terrible to have a low PO2, always correct it, always. So, if we look at the simple scheme of the heart and the lungs, the SVO2 is the saturation of the hemoglobin in the pulmonary artery just before oxygen comes in contact with the blood. Of course, it's mixed venous. It comes from all parts of the body, the brain, the gut, the skin, everything. But if we think about it, it's the same thing for cardiac output. When we evaluate cardiac output by any method, we don't know what's going to the brain, to the heart, to the skin, to the gut. So, yeah, it's a global measure. And the normal value is about 75% in textbooks, but in acutely ill patients, it's about 70%. Because, why? Because critically ill patients usually have a lower hemoglobin level than you and I. And anemia leads to a reduction in SVO2. Let me show you that. Let's take some numbers for oxygen delivery. Let's say a cardiac index of 3 liters per minute per square meter, an oxygen saturation of 96%, and then there is this constant value. So the baseline oxygen delivery, let's say, is about 500 milliliters per minute per square meter. Now, in the presence of anemia, the hemoglobin level could go down by a factor of 2. If it's anemia, not bleeding, no, anemia, normovolemic anemia, cardiac output could double. So oxygen delivery could be maintained. We could double the cardiac output. In the presence of severe hypoxemia, with the SaO2 going down to 48% by a factor of 2, that's a PO2 of about 27 millimeters of mercury. Oxygen delivery could be maintained by a doubling of the cardiac output. Patients with severe anemia, with severe hypoxemia, usually have a normal lactate level, or the lactate level is hardly elevated. Now, if there is a low cardiac output, we cannot compensate for it. So we are much more threatened by a decrease in cardiac output than by a decrease in hemoglobin level or oxygen saturation, because cardiac index can be a reserve for a reduction in arterial oxygen content. Now, if we move to consumption, as I said, the only additional variable will be SVO2. Let's say 72%, okay? So, yeah, oxygen consumption is about 1/4 of the oxygen delivery. We extract only 25% of the amount of oxygen going to the organs. Now, in anemia, we said that cardiac output could double, but if there is such a reserve, don't you think that the heart could be spared a little bit? So cardiac output would still go up, but extraction would increase as well. And that's actually what happens in anemia. There is an increase in cardiac output, and there is a decrease in SVO2. In hypoxemia, it's slightly different because, as we said, when SVO2 goes down, there is no other way around. The SVO2 must go down. So SVO2 will always be very low in severe hypoxemia. That's corrected. Okay? Never allow a patient to be severely hypoxemic. But interestingly, if cardiac output goes down, there are 3 mechanisms, right? Can you remind me the 3 mechanisms for a fall in cardiac output? Hypovolemia, a cardiac pump problem, myocardial infarction, ventricular tachycardia, other major arrhythmia, or obstruction, massive pulmonary embolism, tension pneumothorax, tamponade. There are only 3 causes of a low cardiac output. Cardiac output could go down. We have this reserve that could help us to maintain our oxygen consumption constant. In either of these 3 conditions, SVO2 will go down. So whenever oxygen delivery is threatened by hypoxemia, anemia, or a low cardiac output, the body can still go into the reserve. Now, of course, if we avoid hypoxemia, then a low SVO2 can be due only to anemia or inadequate cardiac output. But that's when the patient is at rest. Now, during exercise, in you and I, when we jog, when we play tennis, when you go fast on a bicycle, we increase our cardiac output. We all know that. But we also extract more oxygen. Our SVO2 goes down. So a low SVO2 is a sign of very good health. It's not necessarily bad to have a low SVO2. Now, the patient may not play tennis in his bed, okay, but still there may be stress. There may be agitation, and this can also decrease SVO2. So to summarize, if oxygen demand stays the same, if cardiac output goes down, SVO2 goes down. If hemoglobin goes down, SVO2 goes down. If oxygen saturation goes down, SVO2 goes down. But here, in the last 2 cases, anemia, hypoxemia, cardiac output increases. If there is an increase in oxygen demand, like in exercise, cardiac output increases, SVO2 decreases. And in sepsis, it's like exercise. No. Like cirrhosis. Sepsis, like cirrhosis, is characterized by peripheral abnormalities as well, so that cardiac output will increase, but SVO2 will be normal or high. SVO2 is typically normal or high in sepsis. So to return to my train story, if there is less coal on the train could go faster. and still bring enough coal to the factory. Now, if the train is very slow, the factory will extract more coal. There will still be less coal in the train leaving the factory. But if the factory works a lot, the train will go fast, and still there will be less coal remaining at the end of the factory system. So this brings this very important diagram. SVO2 low, it could be hypoxemia corrected, or it could be increased oxygen extraction. Then you look at cardiac output, you evaluate, you measure or you assess cardiac output. If it's high, look at hemoglobin, because if the hemoglobin is low, it could be just anemia. But if hemoglobin is normal, then it's like exercise. If the cardiac output is low, then evaluate the 3 types: hypovolemia, myocardial problem, or obstruction. So a low SVO2 is not necessarily something which should be corrected. Anemic patients may have a low SVO2, and you don't need necessarily to give them a transfusion. Patient with heart failure will always have a low SVO2. They will walk in the street slowly, but they will walk in the street with already a low SVO2 when your SVO2 or mine will still be normal. So a low SVO2 does not necessarily require an intervention. That's very important, because I still read papers from people who say, oh, we want to know what is the minimal SVO2 that we could tolerate. That's not the right question. SVO2 should be evaluated together with cardiac output, because then it can help to evaluate if cardiac output is adequate or not. If cardiac output is high, SVO2 is high, that's typically sepsis or cirrhosis. If cardiac output is high, SVO2 is low, as I mentioned, it's either anemia or exercise. If cardiac output is low, SVO2 is high, your income is low, but you leave much money on your bank account. It means that your expenses are very low. That's the patient after surgery. That's the patient who is hypothermic. Now, if SVO2 is low, that's the low output syndrome, hypovolemia, altered cardiac pump function, or obstruction. So if you see a patient with a normal cardiac output, it's not after cardiac surgery on a little bit of the dobutamine, SVO2 is 76%, that's fine. Stop that dobutamine. Patient does not need it. Why would the patient need an SVO2 of 75%? It's not good to leave patients on dobutamine when they don't need it. And if it's another patient with severe lung infection, and if in this case SVO2 is 60%, maybe you need to give fluids, or perhaps a little bit of dobutamine in this particular patient. You see, you need to individualize the therapy, combining the different variables. That's the beauty of our profession. So I could go on and go on, but let's, I see the time running. Let's consider the SVO2 in the pulmonary artery and the SCVO2, which is of course more accessible with a central venous catheter. Very easy to introduce it. But of course, there may be differences between SVO2 and central venous O2. In particular, we know that the kidneys do not extract much oxygen. There is a lot of oxygen in the renal veins. But the heart extracts a lot. And if you look at the central venous oxygen saturation in the upper part of the body, you don't have this renal oxygen saturation and the cardiac oxygen saturation. So it's a rough, very rough estimate. So when you look at these studies, like this classical study from Konrad Reinhardt, you may say, no, it's not very good. The absolute values do not correlate well. And you may say that, you know, for a given SVO2, you can have a relatively wide range of SCVO2. Well, this has been shown in a number of studies. Now you could say, oh, the delta is good. I look at trends. It's not really better. The SVO2 may not change, and yet the SCVO2 may change quite a bit, and vice versa. So, okay, it's a rough estimate. Delta SCVO2 is not better than absolute SCVO2. SCVO2 is the SVO2 of the poor. But in sepsis, as I mentioned, we anticipate that in view of the peripheral alterations, the SVO2 should be normal or high. Is it metabolic shunting or is it anatomic shunting? Now we speak about cytopathic hypoxia or microvascular alterations. We don't know. It's impossible to make the distinction in patients. The resulting phenomenon will be that indeed SVO2 will not be very low. Now, it's not that the extraction is maximal. No. SVO2 can sometimes be low in septic patients. Even in dying patients, this was shown many years ago. In dying patients, oxygen consumption can be normal for a while before it goes down. So oxygen extraction can still increase for a while when you discontinue your inotropes, when hypotension becomes more severe, when the patient is dying. Oxygen consumption can still be maintained for a while, indicating that oxygen extraction is not maximized. But in terms of emergency treatment, Dr. Rivers, in the early goal-directed therapy strategy, could actually show that by maintaining SCVO2 at normal high level with more fluids, with dobutamine, with blood transfusions, we could actually, by doing that in the first 6 hours, we could actually result in better outcomes. We could improve outcomes. Vasopressors, no difference. Mechanical ventilation, no difference. If anything, we could stop the vasopressors earlier. Now, 3 large trials have not shown any reduction in mortality rate. But in all of these trials, the SCVO2 was normal to start with. So it's useless. This is totally useless information. You would do that only when the SVO2 is low. So it doesn't help at all. But it shows that we should not apply simplistic protocols. And we should realize that, you know, there were problems with this large prospective randomized control trial. Now, if you don't like early goal-directed therapy, I don't care. But say yes to SVO2 in an individualized approach. Dr. Gattinoni showed that just trying to maintain SVO2 at the normal level in heterogeneous patient populations does not change mortality. So there is no magic number, no magic number. So that's how I wrote this piece with Daniel De Backer. We can move from early goal-directed therapy to later SCVO2 checks. If you're a patient with sepsis, septic shock, rather, does not improve, check the SCVO2. If it's lower than 70%, consider more fluids, a little bit of dobutamine, just a little bit, or transfusion if there is anemia. So you see, going back to my earlier figure, now I put the therapeutic implications. And that can help me to individualize my therapy. If the patient is still in shock and anemia, there is good evidence that we published recently to show that a blood transfusion could help the tissues to actually consume more oxygen. And now we explore the strategy consisting in giving blood to patients having a low SVO2. Not only because they have a low SVO2, but the low SVO2 could help to guide our decisions. High SVO2, as I indicated, that's typically cirrhosis, sepsis. It's not because the SVO2 is high that everything will be fine. No, but we are not looking at prognostic indicators. We are looking at variables that could really help us to better treat our patients. And if you like, you can also combine it with veno-arterial PCO2 gradients. You take blood for a PCO2 there, you look at the arterial PCO2, and if the gap is increased, as we showed in animals many years ago, it means that blood flow is not sufficient. So that would be a clue to give perhaps some fluids, or if not well tolerated, a little bit of dobutamine. If the SVO2 is low and the delta PCO2 higher than 6, we are clearly in an abnormal situation. But if the SVO2 is okay and the delta PCO2 increased, that suggests a persisting hypoperfusion that we should correct. So you see, SVO2 in complex cases, veno-arterial PCO2 gradients, and there would be an argument for more fluid, transfusion, dobutamine. So we need to integrate variables. We should not look at a single variable. And, you know, some people say you should combine it with lactate. No, you should look at the two, but not necessarily together. First of all, during your resuscitation, the SVO2 will increase much more quickly than the lactate levels will go down. So that's already a very, very strong argument to avoid looking at the two together. But repeating the lactate levels could help you to see if your patient is improving. If you think your patient is improving, but if the lactate levels do not go down, perhaps you are a bit optimistic. Or if you think that your patient is not improving, but lactate levels do go down every hour, then you could think that you are a bit pessimistic. And perhaps the situation is not too bad. Perhaps we should not be too excited. And as you know, we can check lactate levels every hour to see how the kinetics evolve. So this is very helpful to interpret cardiac output. If cardiac output is inadequate, there can be either an increase in cardiac filling pressures indicating that the heart is not doing its job properly, or that there is a reduction in SVO2 that could indicate that the heart may not do the job properly, or there may be inadequate volume on board, or not enough red blood cells. Think at the patient after surgery, if you deal with these patients. When they come back from surgery, they usually have a very low oxygen consumption. They are anesthetized, they are still on mechanical ventilation. But then they will wake up. And then they may have a supranormal cardiac output. And in these conditions, monitor SVO2. And at the end, if the SVO2 is low, you may have to give fluid transfusions to butamine. But if the SVO2 is above 65%, let's say, well, if there is tachycardia, then you may give beta blockers, especially if the patient was treated by beta blockers before. I know some people who just look at heart rate in septic shock patients and say, oh, heart rate is fast, let's give some beta blocking agent. That's terrible. If you don't know anything else, you may just kill your patient with your beta blocking agent. But if the SVO2 is normal or even high, well, if the tissues are well perfused, yeah, that may be an indication for beta blocking agents. And finally, you could even look at the relationship between cardiac index and oxygen extraction. I like to do that because if the patient is there, that's typically sepsis or cirrhosis. If the patient is there, it's typically anemia or exercise. If the patient is there, low cardiac output, high oxygen extraction, it's typically a low flow state. And if the patient is there, low cardiac output, normal or high SVO2, it means that the patient has a very low oxygen demand. The patient is probably sedated on mechanical ventilation, maybe hypothermic. So it's really interesting to understand what the patient has and choose the right therapy. A low SVO2 is not always pathological. A high SVO2 is not always a good sign. SVO2 should not be always maintained above 70%. No, only in septic shock when the patients are not improving with your initial therapy. And it's good that things are not so simple. Otherwise, it would not be fun to be an intensivist. Muchas gracias.
Audiencia que decidió participar de esto. Esperamos que hayan disfrutado, aprendido y se hayan inspirado tanto como nosotros al escuchar a los expertos hablar de estos temas que tanto nos interesan. Por supuesto, queremos agradecer a todos los profesores. Fueron ponencias magistrales, excelentes, y un agradecimiento muy, muy especial a todos ellos. También, por supuesto, queremos agradecer a todo el personal que hizo posible en cuanto a producción y patrocinios este foro, especialmente a VITT Américas. Muchísimas gracias por hacerlo posible. Y bueno, agradecer a toda la producción. Un recordatorio solamente de que las constancias se podrán descargar por correo electrónico más o menos a mitad de semana. Y bueno, pues esperamos verlos pronto, el próximo año, en un escenario similar. Muchísimas gracias a todos y bueno, que tengan una excelente tarde.